it's Friday morning, to address them. Recent changes in health and public health systems over the last few years, with possibly more to come, makes filling those gaps both more pressing and more difficult. And we believe very strongly that a key data gap is around MSK, data around community care. And that's why we remain very strongly committed to the development of a national MSK audit. So we're pleased to see ongoing conversations between NHS England and HQIP exploring the possibility of commissioning a new audit focused on MSK services delivered in community settings. In these data meetings, we seek to dive into some of these big questions, to spark curiosity and conversation, and to foster a spirit of collaboration that leads to improvements in outcomes for people impacted by arthritis and other MSK conditions. So I'm excited for today. We've got 3 cracking panels for you, and they'll each be presented in turn, but let me just give you a sneak peek. So the first one is on epidemiology of MSK conditions and chronic pain. Versus Arthritis delivers a range of pain management services. And actually, it's often the area that people tell me, will come up to me at different events around the country and say, "You have changed my life. You have given me my life." It's a really core part of our service offering. But we've also invested very heavily from a research perspective. So including through our long-term investment in our pain centre, and more recently in our £12 million grant to Advanced Pain Discovery platform. We've done that because people with arthritis and musculoskeletal conditions told us that this was their #1 concern. We know that people experience pain in different ways due to factors such as gender, race, age, amongst other things. So I'm excited to hear more from our 2 presenters today on this topic. Equally, versus Arthritis, our new strategy prioritises understanding more about inequalities, including deprivation and the impact on people with arthritis. What we do know is that if you are poor, you're more likely to develop arthritis 7 to 10 years earlier, to be living with multiple long-term conditions. So I'm looking forward to hearing the presentation on patterns of inequalities in illness by deprivation. The second panel is on population health management. So we know that people with arthritis and musculoskeletal conditions may need support to return to and remain in work, and suddenly they are in the spotlight. With all political parties fixed on economic growth as a way out of our current financial crisis, the fact that MSK conditions are amongst the top reasons for people being economically inactive has meant that attention has finally turned, somewhat belatedly, towards musculoskeletal health. Yet there's no one silver bullet. There are so many reasons people with arthritis and MSK conditions are unable to work, including the depth and unpredictability of their conditions, the long waits for surgery, lack of appropriate work-related support. We're staggered to learn that only 5,660 people with MSK conditions gained support through access to work in 2019-20, given the scale of the disease. And even simply, what jobs people are doing. Given that there are now over 2 million people over the age of 65 living below the poverty line in the UK, in a country with one of the least generous state pensions in the developed world, this is doubly pressing. So I'm really looking forward to hearing more on this topic and current initiatives later on this morning. Also, as someone living with osteoarthritis and having watched how it gradually stole my late mother's life and independence from her alongside her other comorbidities, it's a topic I've a vested interest in. So I'm also looking forward to learning more about the classification of OA through clusters of comorbidities in our second talk on this panel. It's just worth noting that people living with multiple long-term conditions are a priority for the Richmond group of charities, of which we are a member. For those of you who don't know, the Richmond group brings together some of the largest health charities in the UK, and together we try to shine a spotlight on this important area of health policy and the need for greater coordination and joint-up services. Our final panel is on how we can improve data to improve health services, which is so very topical in our current overstretched and underfunded NHS. And there are lots of initiatives currently underway, and some of which we're involved in at Versus Arthritis, and that we'll hear more about today. So finally, I just want to say what's really clear to me, and I guess to us at Versus Arthritis, is that we need to ensure that arthritis and musculoskeletal conditions are a priority for our new government and our NHS, no matter who is in power, come the 5th of July. So we recently launched our election manifesto with our top-line priorities for the next UK government, setting out how those in government can make arthritis a priority. If you haven't seen it, you can find it on our website. I'm sure someone put a link in the chat. And please help us share it far and wide to ensure that all party candidates are aware of the pressing issues faced by people with arthritis. And if you can, take part in a very simple action. It's a click of a button to write all of your party political candidates, to just raise awareness with them and to ask them to support us post-election as well. So it's definitely enough for me. Let's get on to the presentations, but I do hope you enjoy the meeting. Please stay engaged with us and let's keep talking through. Thank you so much.
Thank you. So I won't repeat all the welcomes. If people are online as well, there's lots of introductions going on online, and please do keep the questions coming and the conversation. It's something that you get online that we'd struggle to get in the room, except when we're at tea. You'll have to make your own tea if you're at home. So for our first speaker, where's Rosemary gone? There you are, Rosemary Monk. So Rosemary, it's wonderful to see you again, wonderful to welcome you here. So Rosemary, many of you will already know, is a senior clinical lecturer in rheumatology at the University of Aberdeen, studied medicine at the University of Glasgow, and completed her specialist training in 2017 in rheumatology. She holds an honorary consultant rheumatology post within NHS Grampian, where she plays a key role in service development and improving care for those living with rheumatic and musculoskeletal conditions. Rosemary is going to talk to us about improving care delivery and outcomes for people with vasculitis, and you'll have to explain to us what vasculitis is. Okay.
Thank you very much, Benjamin. And can I just move my slides like this?
Yeah, you click on the press the space bar.
Oh, it's fine. So just press on the screen and welcome. That took about me. You don't want to be too close then, and that's not. Thank you very much. Yes, I've come down from Aberdeen, where it's also sunny, but not quite as warm as it is here. So I'm going to talk to you about the Voices of Vasculitis study. So this is a Versus Arthritis funded study that started in 2019. And it's about improving care delivery for people with vasculitis. And these, I just wanted to say at the start, our patient partners have played a key role in designing, delivering, and co-producing the recommendations from this study, and that is a picture of our partners there. So, collectively, it's not rare to have a rare disease. It affects about 4 million people in the UK, and about 20% of rare conditions are non-genetic. And vasculitis is a very good exemplar of a complex non-genetic, rare rheumatic condition. And Deborah was talking about health inequalities. These people really struggle from a triple whammy, if you like, of health inequalities. So they struggle to navigate healthcare systems that are designed for more common conditions, high volume, low complexity conditions. They have conditions that affect multiple body parts, that have complex, expensive treatments, that involve steroids, they're prone to morbidity and multiple long-term conditions, as well as all the other health determinants. Recognising that, there's a real drive, both nationally and internationally, to reconfigure services to better meet patient needs. But to date, there has been very limited evidence to inform that. So, for example, in stroke and heart disease, for example, we know that if we get people quickly to specialist centres, then they do better. But we simply just don't have that evidence in the rarer conditions to inform care. And that's what the Voices study set out to do. So firstly, what we wanted to do was identify what were the key service components underpinning good care. We wanted to explore the links between these service components and individual health outcomes, which hadn't been done before, as well as look at some of the barriers and facilitators to delivering these key components in practice. And as I said, our patient partners were key throughout that. And what we did was a mixed method study. So we took qualitative methods and quantitative methods together to do that. So firstly, we conducted an online survey of vasculitis providers across the UK and Ireland, and we interviewed people living across the UK with vasculitis. And we brought that together to try and understand the different service models and components of services and what people thought was important, and really importantly, to try and understand what good care looked like from a patient perspective. We also used that to inform our case studies, where we took a deep dive into services across the UK. And we did this in Scotland and England as well, because it's really important we can learn from each other, speaking to a broad range of healthcare professionals, to look at some of these service components and how they might be arranged and organised in different ways. We also spoke to staff as well, again, to get their perspectives of what good care looked like. And we brought that together in the survey and the interview data to identify these key service components that support good care. And we then took that into our population level data in Scotland. We're very fortunate in Scotland that we've got linked outpatient hospital records, prescribing, and we were able to identify almost 2,000 people across Scotland with vasculitis. And because we had survey responses from all across all services in Scotland, we were able to determine whether these people had been looked after in services which had specific components. And that enabled us to look at the association between being looked after in a service where you had these components and individual health outcomes and healthcare use. That's things like infections, cardiovascular disease, cancer, emergency admissions, etc. And then we were able to go back to the survey and see, well, when we identified these key components, how available were they? And the factors explaining their findings. So it was quite complicated. It sounds easy, but it was quite challenging in practice. So I said we identified key components that facilitated good care. And as I said, we took the patient experience data, the case studies, and the provider survey together. Perhaps unsurprisingly, both people living with vasculitis and clinicians valued continuity of care, timely response to illness, and support for shared decision-making. And what does that look and feel like in practice? That's about combining and connecting care, being in the loop, and feeling safe. And that was a really important thing, that actually our patient partners looked at our data, and that was something that they felt very strongly came out, both from staff perspective and patients, about being looked after and working in a service which felt safe. We also looked at the different components of care, including how it was set up, access and pathways, people, the extent to which it was integrated or not. And we brought this together to identify these key service components that facilitate good care. And this was around timely access to services, things like how quickly you can see a new patient with a suspected case of vasculitis, whether you had a vasculitis specialist nurse or nurse advice line. Integrated care, like cohorted clinics. Can you see all your vasculitis patients in one place together? Do you have nurse-led clinics? And access to expertise, such as specialist multidisciplinary meetings. And so just moving on to then some of the associations that we found, we then looked at that in our national data set. And we found that new patient waiting times less than a week were associated with 30% fewer serious infections, 22% fewer emergency hospital admissions, and although it's not shown on that figure, a 41% reduction in mortality here. And why? What was behind that? And I think it was very clear from the qualitative data that this wasn't just about whether you could, how quickly they could be seen from referral to clinic. It was about streamlining the pathway. Where services had been successful, it reflected efforts to improve the whole pathway, not just the waiting times once they'd been made. And this is just a quote here that illustrates that. We spent quite a lot of time educating GPs about vasculitis, knowing which tests to do, where to send them, who to contact, so we tend to pick up people earlier. Nurse-led components of care were really important, and nurse-led advice lines were associated with 24% fewer serious infections and 15% fewer emergency hospital admissions. And this focused around timely access to care and coordination. Most of the calls were about flares. This was about a single point of contact where people could get in. Nurses were perceived to be more accessible than medical staff and providing that holistic care. I'm their go-to. They'll talk to me about everything. A lot of it's managing side effects of medications and flares. And they also played a key role in coordinating patient care, stitching the whole thing together a bit more. Cohorted clinics, as I said, seeing people all together, were associated with 25% fewer serious infections and 19% fewer emergency hospital admissions. And nurse-led clinics were associated with 35% fewer serious infections and 25% fewer emergency hospital admissions. And again, that was all about support for care planning and continuity of care. That was about, from a professional perspective, getting into vasculitis mode to be able to protocolise management, proactively plan care, build relationships. You know who's coming, you know what you need to focus on. Whereas, as they say, if somebody pops out randomly in a general clinic, it takes you back and you think, oh, I need to flip out of rheumatoid arthritis mode. Nurse-led clinics also enabled a more holistic approach to care, longer appointments. People felt they were able to open up. It's a good proper sit down, go over any issues. We have so much more time, pick up on drug errors in previous clinic letters and things. A nice kind of holistic review. And finally, access to multi-specialist, multidisciplinary meetings were associated with 28% fewer serious infections and 14% fewer emergency hospital admissions. We tried to look at the independent effects of these service components on health outcomes, and that's quite challenging because often these components exist together. But in saying that, waiting times for new patients less than a week and the nurse-led components of care appeared to be independently associated with fewer serious infections, emergency hospital admissions, and reduced risk of mortality, although there's quite a lot of uncertainty around that. Key components overall were characterised by their ability to overcome professional tensions between specialties. Vasculitis is looked after by rheumatologists, by nephrologists, by ophthalmologists, ENT, and there's tensions there. Support for continuity of care was critical between clinicians and patients, relational continuity of care, coherence and consistency of care between teams, as well as knowledge of patients' care and situations. All of these components supported timely access to expertise and fostered this sense of feeling safe. And this is summed up, I think, really nicely by this quote. People seem to absolutely, even if they're not unwell, need a sprinkling of direct contact to sit down and plan the future, because most of what you do is building that long-term trust and relationship for the bumpy bits in the future. And I think that's really important when you're thinking about sort of complex, rare rheumatic conditions. We then went to see well, okay, we've identified these key service components that are really important. Who's got them? And as you can see here on the right, where people struggled, services struggled, was in the nurse-led components. Only half of services surveyed had access to a vasculitis specialist nurse, and just under half had a nurse advice line, and only 36% had nurse-led clinics. Don't have time to go into the details of the facilitators and barriers to delivering these components. That's a whole separate talk in itself. But needless to say, we found a number of factors at individual, professional, organisational and policy level. And we've got really important learning there that will help, hopefully, support implementation of these key components. So, pulling it together, what have we learned from Voices? Well, we've identified key service components associated with improved health outcomes in an exemplar group of rare conditions. We've provided insights to support integrated care delivery and sustainable services for people with rare or rheumatic diseases. And I think these are a group where they really do have that triple whammy of health inequalities. And also, looking at this data and looking at key service and experience outcomes provides a framework to evaluate different service models. And finally, engineering impact. This evidence is already informing clinical service standards, NHS England rheumatology specialist commissioning, as well as the updated clinical ankylosing guidelines. And finally, patients have played a really important role in generating impactful findings grounded in patient experience. And Benjamin is hovering, I need to leave. Finally, our patient partners have also helped us create resources for people with vasculitis, which can be found at healthtalk.org, and a Catalyst film, which is designed to help services improve care. So please do have a look at those. Thank you very much.
Thank you so much, Rosemary. Fantastic presentation. As you started off, I started thinking about the sort of classic structure, process, outcome ways of measuring quality. And then listening, I thought actually what another framework which you articulated was that services need to be responsive, expert and connected. And the expert includes the person with the condition. And that's where the shared decision making comes in. So it was brilliant. Please do keep questions in the chat. Think of questions. We're going to press on. And then we'll do some Q&A before the break. I hope there'll be time. Una Nicholson. Hi, Una.
Hi.
So Una's going to speak about conversation, not consultation, and the data-led approach to musculoskeletal care in the community. And you have come from, you're the head of people, community and equity for Sussex MSK partnership. And I'll just do a little bit of embarrassing biography. They are by definition American. Yeah, I mean, it's not written. No, yeah, exactly. That's the deal. Sussex MSK is a unique local not-for-profit partnership bringing together primary care, specialist musculoskeletal care, community and mental health, and wellbeing experts to deliver the whole musculoskeletal service in Sussex. Last year, your community appointment days garnered national interest, been covered all over the place, and were commended by MPs and the NHS as an example of innovative community-based solutions for getting people care more quickly. And we've read the coverage in Health Service Journal and indeed all over the place. So we're really looking forward to hearing from how you use data to make that all happen. Over to you.
Thank you. Actually, I'm going to continue some of the themes that Rosemary was just talking about accessibility and how important it is for people to be able to have conversations about what really matters to them. So I'm going to ask you to think back 2 years ago. We're emerging out of the pandemic. And after 10 years where we steadily reduced our waiting times, suddenly we are back to sometimes something like a year's wait. So during the pandemic, a lot of our clinicians were deployed to the COVID frontline. We didn't actually close our doors. We did lots of remote working, but basically we were back to this situation where wait times were extraordinarily long for musculoskeletal appointments. But on top of that, our colleagues were telling us how dispiriting it was to work in that same old way of seeing what that sense of isolation, of seeing one person in a consulting room. The other thing that was new and was really opening our eyes was the impact that we saw during the pandemic of health inequalities. So we built these new data dashboards that were showing us who was using our service, but more importantly, who wasn't. So in Sussex, we did say at the beginning, so we're based in Sussex. Our service is community musculoskeletal services for Brighton and Hove, Horsham, Mid Sussex and Crawley. We have some of the highest levels of deprivation in the country in Brighton and Hove. We have areas of great rural affluence in Horsham and Mid Sussex, and we also have areas of acute health inequalities in Crawley, where, for instance, I'm here with my lived experience leader, Norman Webster. So, how many people are unregistered with a GP in Crawley? So, something as a percentage, can you remember? It's big. Basically, there's lots of people.
Repeat what he said, we didn't hear.
Oh, beg your pardon. So there's around 1,000 people in Crawley who aren't registered at all with a GP. So we don't have any data about their access to care. So we wondered, as we came out of the pandemic, we wondered if this was an opportunity to really do something different, to rather than thinking about better engineering our flow of people to get people seen quicker, we wondered, is there an opportunity to actually do something really radically different? So we created these community appointment days where someone with an MSK condition, they could have trouble with their shoulder, with their knee, with their back, comes along to a sports centre where we have everything that they would need. So there would be you would have access to a one-to-one assessment with a physiotherapist, advice and guidance. There would be physios there on the day to help you to create your plan. We also had health checks there, and also we invited community and voluntary sector organisations to come along and be there. So instead of a situation where you sit on a wait list for 30, 40 weeks, see someone who perhaps isn't the best person for you to see, just to go and sit on another waiting list, we thought, what would happen if we bring everyone that a person might need into one place and then invite people to come and create their own path through that. I have to say, our colleagues thought we were crazy. There was quite a lot of fear. Like we invited over 1,000 people to come. The slots, one of our learnings was the slots went immediately, and we realised, we need to put those who don't have digital access, we need to give them access to book first. So there was some learning as we went along. There was a lot of apprehension about what that would be like to invite hundreds and hundreds of people in one place. There was a lot of conversations about chairs, because we chose a sports centre where they don't have chairs. And we know that if you have a musculoskeletal condition, you don't want to be standing around for a long time. You don't want to be queuing. So we created basically a new model of care. And we were extremely grateful to our colleagues who all threw themselves in to give it a go. The key essential ingredients to it were, we thought about what do we need to take away. So our colleagues in their consulting rooms were telling us that actually having timed appointments was working as a barrier. rather than helping them to do their best work. Their vocation is to connect with the person in front of them around what matters to them and help them to build their plan for their own recovery. And that timed appointments, doors, physical barriers, were all working as a barriers to them doing the work that they really wanted to do. So we created a flow. So when you arrived, you got a passport in which you were invited to write what really matters to you. So the first thing that happens is you have a what matters to you conversation. And then each person was facilitated to find their own way. So it was about conversation, not consultation. It was explicitly community powered by having we invited people from the community into the room. And we captured data. I will show you the data slides in a minute, but we collected outcome data and inputted that into, we use System 1. But we also asked people the degree to which they felt the effort had been made to help them to understand their own condition. The effort had been made to understand what really mattered to them, and the effort had been made to support them to work out what they should do next. So what did we learn? We invited, in the end, we had 550 people come over 2 days. The responses to those questions, the degree to which people felt that the effort had been made was extraordinarily high. We're talking 11.2 out of 12. So we saw a highly personalised response. But kind of best of all, in terms of this experience of a new model of care, what we found was that just over 50% of people were able to get what they needed in that room on that day. So the purple is the total number of people who came to each day. So these are 2 days. And it was interesting also that Crawley and Horsham are very, very different socioeconomically, but we saw almost exactly the same pattern. And usually in our community service, we see significantly different outcomes for people of different backgrounds, ethnicity, access to wealth and resources. But at this particular day, I believe that conversation rather than consultation mitigated against the usual amplification of social inequality in health services. So almost 300 people each day, around half of them got what they needed. And then around 20% of those have since then come back to the service saying, I need something else. We'll share these later, right? So people can look through the feedback. I mean, the people who came really, really loved it. And we gathered, we wouldn't let them leave until we got their feedback. We did design capturing feedback into the day because it was so important we understand what the experience of people was. Yeah, as you see there, people felt that they were really listened to, that people took time. But on top of that, the staff experience was also really incredible. They absolutely loved having that opportunity to work alongside each other, to be able to just go and ask the expert, in the room, rather than needing to task someone or make an appointment in so many weeks' time, to just be able to say, oh, yes, Toby, he's brilliant at this. I can go and ask him. So the staff were really, really proud of what they created for each other and also just really enjoyed being together. That's more of that stuff. Yeah. Benjamin, is this my time?
No, you're good. It's just because you said
I just stood up as you suggested.
Okay.
Thanks for telling.
Yeah, so conclusions. We are still studying to see what happens. Is it possible to give people all they need on that one day, and then how many people come back over time? There has been some learning in terms of who comes to days like this. We've seen that those are older people from our communities are more likely to come to these than the younger ones. It kind of makes sense. It's in the middle of a working day. And in terms of socioeconomic background, those who have more access to wealth were more likely to come to this. So it's also reinforced to us that we need to do more of that actually outreach, going to people where they are, rather than this is community-based, but probably doesn't go quite far enough for certain groups of our communities. We got, as Benjamin was saying at the beginning, we got quite a lot of attention. Amanda Pritchard tweeted about us, where Streeting mentioned this piece of work as an example of community services finding new ways to work within existing resources. And since then, we have shared our learning from this with trusts up and down the country, and there have been people have created their own community appointment days, which is great. I think that's probably, that's the next one. That's probably our story for now, unless there's anything you wanted to add, Norman. Okay.
Thank you so much. There's some comments and questions in the chat which we'll come back to, so please keep them coming if you're sitting in the room and have some questions. And again, lots of themes that link to the presentation just now. The third presentation then of this tribe for the using data to improve health services, and we're going to be talking about a project called PEAKS, and no doubt we'll hear what PEAKS stands for, as Mary already know. Sarfraz Geraj is going to be speaking, just checking you were here. And you're the clinical lead on the PEAKS project, Mind and Body Programme at King's Health Partners. You're a clinical, and we've got Natalia Stepan as well here. Hello, Natalia. So Sarfraz, you're a clinical psychologist, been supporting people living with chronic pain since 2015. You're an experienced group facilitator, and you can do the next session if you like, and is keen on exploring the biopsychosocial mechanisms, there's a word, biopsychosocial, and the mechanisms that contribute to the onset and maintenance of chronic pains, that's persistent pain, and addressing inequalities in healthcare. You're currently the clinical lead on the PEAKS project. We're really excited to have you here. And here, Natalia is the program director for the King's Health Partners Mind and Body Programme, which works predominantly with colleagues in South East London to promote the integration of mental and physical healthcare. She has previously held strategy and policy roles in King's College Hospital and NHS Improvement. So welcome both. Thank you so much.
Hi.
Surprisingly close to your mouth.
I don't know if I've ever spoken into a microphone before, so this is a weird one. But thank you so much. It's great to be here today to share one of our projects from South East London. So PEAKS, I am sorry about that acronym. It stands for Pain, equality of care and support in the community. It doesn't actually spell out PEAKS. We've had many workshop sessions to improve it, and we really need to, so just apologies. But yeah, so we're based in King's Health Partners. That's a partnership of South London and Maudsley, King's College Hospital, Guy's and St Thomas's, and King's College London University. And so today we've been asked to speak about some of our local data, what we actually did to respond to it, and then what more we've learned as a result. So last year, for anyone who was at this conference, Dr. Mark Ashworth presented some of his data, some of the work that he's done about the
chronic pain prevalence in our local area in Lambeth. And I don't want to kind of go over all that again, and by far not an expert on the data. So Dr. Mark Ashworth, he said, very happy for me to share as far and wide as we can. But I just thought it would be worth recapping it as a kind of basis for what we did. So chronic pain, although it might not always show up so neatly in our data, is one of the most common long-term conditions, both in our local area in Lambeth, but actually according to lots of reports more generally across the UK. And locally in Lambeth, we see large ethnicity-related differences in chronic pain prevalence, with highest prevalence seen among women from Black African and Black Caribbean backgrounds, as you can see on these graphs here. So obviously chronic pain is a really big challenge for the people who are living with it, and has huge impact on people's lives. But it's also a big challenge for primary care. So another one of Mark's findings is here on this graph. Chronic pain accounts for the highest number of GP appointments in Lambeth. And we've seen some separate data from one of our primary care networks that shows that half of all long-term frequent attenders to GP practices have chronic pain. So we know that chronic pain is highly prevalent. We also know that women from Black backgrounds are more likely to experience chronic pain, and there are additional healthcare inequalities here as well, such as in the attitudes of healthcare professionals. We have also seen some indications that there are inequalities in access to pain management services. Deprivation, as has been mentioned, is another relevant factor, and that we've seen that chronic pain cases are increasing, but they are increasing at a much faster rate for people who are living with deprivation. And at the same time, we all know that services aren't really able to keep up, and waiting lists for pain management services are increasing. While I know that I don't have to convince anyone here of the importance of chronic pain, what we wanted to talk about, what we've been doing in the PEAKS project, which Safraz will tell you more about, is trying to co-design and test a new approach, not just how we can more effectively support people with chronic pain, but also how can we give priority to people who are more likely to experience chronic pain, and how can we start to more proactively address some of the health inequalities faced by these groups. We're also, I should say, really convinced that we need a biopsychosocial model of care to support people. I know it's a buzzword, but chronic pain affects every single part of our lives, and there's a little stat there. Depression is 4 times more common among people in persistent pain. And I work in the mind and body program, so of course I'm going to say it. But everything that we have been doing has been really thinking about how can we provide a really joined up holistic service for people. So now I'll just hand over to Safraz.
Thanks, Natalia. So in talking about how we put the PEAKS project together, we went right to the beginning and considered the voices of the people who are living with chronic pain in our borough. And there were a vocal bunch. They were ready to really tell us what they were thinking. And the elephant in the room needed to be addressed, and they were talking about racism. And you think, well, what's racism got to do with your experience of chronic pain? And I guess looking more into the wider literature, we considered the role that structural racism plays in the development and design of services, and not necessarily just structural racism, structural misogyny. It's white men who design services, and there's no connotation that this is anything is being done intentionally. If I was to design a service, I'd design it in my image. So it was really important for us to undertake a co-design process that actually listened to the needs and the wants of the people who are struggling most disproportionately in Lambeth. And what this co-design process that looked at heard the voices of people struggling with chronic pain themselves, their carers, and also some clinicians, found three key areas. The importance of coordinated care. The previous presentation that demonstrated an excellent example of coordinating things in one place. The fundamental need to understand the difference between acute pain and chronic pain. This is a big game changer. And then, a lot of people reported that, even when they did get some attention and some treatment for their pain, they felt like they were just being chewed up and spat out. There was no real sense of care, no investment in how they can manage themselves. And so that was the other key area that the co-design process informed us that we needed to include. So what did it actually look like? So we've got this pathway, starting off with discovery. In order to try and address inequalities, data is our best friend. And with that data, we can understand who is it we need to target. And that's the difference between working, in an equality-based way and in an equity-based way. We need to target the people who need the service the most, those that are often the most disenfranchised. As Natalia said, we targeted the high-frequency attenders. And because of the funding for this project and the stipulation that we need to try and address inequalities, we roughly worked at trying to look at the demographic profile to target more of the Black community. So it wasn't a project that was closed, but it was just trying to emphasize the service provision. The other experiment in all of this was to see, well, how do maybe white men fare in this design process? And hopefully some of the data that is emerging tells us actually it works for everyone when you design something in an equal way. So once we'd got this list of people that we were going to target, call them, engage them in an introductory workshop, engage them in completing the mind and body health check, which again gave us a significant amount of really helpful data, looking at their quality of life, looking at their medication use, pain catastrophization, a lot of the measures that would allow us to really track, is this actually making a difference or not? And some of the thinking around which measures to use were informed by the people we spoke to in the co-design process. So having attended a workshop, people would then have one-to-one assessment, and then we would be able to tailor the rest of the provision. And the rest of the provision really looks like 7 workshops that took a biopsychosocial approach that were based on the pillars of lifestyle medicine. Started off with a workshop run by a physiotherapist. Now, he had a really hard time because most of the people in the room had already had physio and did not like it. And what was really helpful about the physio that we were working with was that he was a specialist in chronic pain. So his understanding of the physio routines you need for chronic pain were different to what he used for acute pain. The assumptions about recovery were very different. So we started off with, the biological focus, so movement, sleep and medication, nutrition, moving on to the psychological approach, looking at emotional well-being, and then a dedicated session on trauma, incredible research looking, emerging data showing that high correlation between people who've suffered with chronic pain and have, experienced a traumatic or a number of traumatic experiences as well. And then moving on to the sort of the sociological aspects, where it's looked at relationships. Unless you've had chronic pain, people don't get it. So how can we get people to get it a little bit better? How can we make people aware about some of the work they need to do when they're in pain in communicating and maintaining the relationships? And then the last workshop, which again, brings together really disparate data on things like poverty. And so why should someone with more socioeconomic deprivation struggle with pain. What's the link? It's not biological. It is lifestyle related. It is to do with the stresses that are put upon the nervous system. And so, although, in a 1.5 hour workshop, we're not going to create an equal society, but what we can inspire people to do and signpost them to is community resources that give them a sense of agency. So instead of feeling like, I'm helpless, which makes my nervous system even more vulnerable and sensitized, actually, if I feel I've got a sense of agency, I can be part of the change. And just recently, being engaged in voting in the election, my right to vote, are the kind of things that people are reporting to say, actually, it's making me feel different. So this kind of takes us through the pathway. Each step of the pathway, we have someone from the local community come in, say, you just had a 1.5 hour intro. What if you want to pursue this? What if you need support in doing this? And that's what the local voluntary care sector can offer in each of these areas. And then just to make sure people don't feel like we've chewed them up and spat them out, we facilitate a peer support group. So they've got that ongoing support, but it's much more self-management based. So people, again, have that self-efficacy, that agency, and from a service perspective, it's not as resource intensive. And the emerging data is fewer GP appointments, reductions in some medications, but I think more importantly, people and through their mind and body health checks are reporting higher quality of life. I'm able to play with my grandchildren a bit more. Yeah, I'm still not playing football with them, but I'm cheering them on from the sidelines. I'm socialising. I'm starting to go out for walks more. And I guess one of the next steps is thinking about getting more into voluntary work. And how can I fulfil those other ambitions if they're indeed mine and not a top-down, we're going to fund this so you can get back into work. So hopefully that gives you an overview. We've in year one, just shy of 600 people supported, and this is another interesting facet of the data. Just wanted to share was attrition. So by and large, the research shows, and certainly my own anecdotal experience working in the London services, is that you already have an underrepresentation of people from minoritized backgrounds at the start, and then that lack of representation gets attenuated as you go along. So the proportion of people from minoritized backgrounds decreases as you go along the pathway. Our data really bucked the trend. Black women became increasingly represented along the care pathway. So when we asked them, they said, what's going on here? This isn't what we normally expect. So, I saw people who looked like me. I felt like I belonged. I felt like I was understood. And there was, I don't think myself and colleagues can take the credit for that. It's just the environment that was set up. So I think some really, really important learnings for us. We're continuing in year two, and the challenge for us now is to think about how we can start scaling this up. How can other PCNs in our locality take this on without the burden of having to find lots and lots of extra resource, but also the tension that you can't do something new. You can't make an initial switch without some resource. So we look forward to working with more partners who can help us roll these things out, that we can learn from, and that we can find more resources to make these significant changes.
I've either got bad hay fever or a slight cold. I just don't want everyone to get back cold. You can't catch hay fever so far. So we have a few minutes. Michael, how many minutes do we have for a conversation?
10 to 15.
10 to 15. Yeah. Okay, so We've got some questions in the chat, and lots of those are quite technical questions, so we're definitely going to come to those. I wanted to start with you if I can. I'm going to run around. I'm going to give the microphone to somebody who doesn't possibly have a cold. Yeah, let's think about that. Yeah, that's why. Every year. Might be not the right thing. I'll shout. So first of all, Rosemary, there was a sort of specific question from your work. Everybody's used data, all three presentations, and actually a real mixture of qualitative and quantitative, which is quite interesting because this meeting has often focused more on quantitative data, and actually today we've heard an awful lot about qualitative data. Which perhaps we underthink about when we think about data. Rosemary, you had lots of quantitative data as well in your mix. Could you say a little bit about how the measurement and the stuff that you were doing, how that has changed services or has the potential to change things for you?
Thank you very much. So I think the value of having the quantitative and the qualitative together is that that's really helped to make impactful findings, and it's helped engineer that impact. So the qualitative helped us identify what the key components were. We could then use the quantitative to link that to individual health outcomes. We could then go back to the qualitative to help us understand more what the data was telling us, because the quantitative can only tell you so much. But at the end of it, in the process of doing that, we had, as you were saying, that co-design, that actual people's lived experiences had helped inform what we explored in the data, and it helped us understand what it was telling us. And now we're in a position whereby we've got recommendations that are grounded in lived experience, and then we're using that to inform guidelines. So what services I've done many talks on the voice study, and the feedback has been, this is great. This is exactly the kind of data we want to enable us to create a business case, to be able to create these, support nurse-led components of care, or whatever it is. And so I think the next step is for us to be able to bring that together into a sort of a usable tool, if you like, for services to say, we can take your recommendations. How can we use this practically at a local level? So I think that's the next step from this. But bringing that different types of data together has been so powerful in speaking to all the different stakeholders and being able to resonate.
Thanks. And I wanted to go to peaks, not ignoring, because we're going to come back to you in a moment. But then I suppose I have a question listening and thinking about all of this. Do we have to, as a community, go through this process each time with every community and every geography that we want to work with? How much is lift and shift? How much can we say peaks have done this year? This group in Bradford, you'll know, have done a lot of this as well. And there's lots of people doing similar things. Is going through the process and gathering the data part of making this work? Or to what extent can we say, right, we now know what to do? And actually, I'd love to ask that at the community appointment days as well. We're seeing those spring up all over the country. To what extent does each community have to go through the data gathering? It's kind of peaks first, but to what extent do we need to go through the data gathering as part of local engagement and changing how we think? Or to what extent can we say, well, this has been done in 3 places, off we go? But peaks first and then counts.
Thank you. And Safas, you might have a different view to me. I think some of it should be done at each kind of, place level, because some of it is about co-designing and better understanding our communities and working with them. I think those things can't be underestimated. I think what we've done a lot of is try and make sure that the content and the speakers and the staff are all reflective of the communities that most suffer with chronic pain in our local area, but that might look different in different places. And so I think but there are certain learnings that we can lift and shift. And certain findings, as Safas also said, that are relevant for it's not for everyone, but for large groups of people, there's the themes of the workshops. There's the importance of continuing support in the community. There's the importance of having time to, speak, be heard, build trust. Those things are relevant for everyone. So I think I would say 80-20 probably. I don't know if you agree.
Which way?
80%, I think we can lift and shift. 20% should be done, I would say, at each level.
Yeah, and I just add that the way we do medicine does need to be reviewed. So just adopting an exclusively biomedical approach, it's not giving the results that we want. It's not doing the people who are suffering justice. So that's definitely part of the lift and shift, is looking at lifestyle medicine, looking at a biopsychosocial approach to inform services.
Conversation about how medicine makes everything worse. Over coffee. Una, and then I've got a couple more questions for the CAD folks from the online.
Yeah, the question makes me think, well, who needs it? Who? So I find in our commissioning environment that the contracting, that the money problems can dial down everyone's imagination and willingness to try something new. I think actually some of the principles that we've heard about this morning of accessibility, of services designed by the people they're for, that putting what matters to you central, we know that matters. I think it's really interesting that there were common themes between all three of us this morning. But when we talk to our commissioners, it's like, show me the spreadsheet, show me how this is going to reduce demand. We struggle to be able to actually put on a spreadsheet how this is going to reduce urgent care need. So I feel like, God, that it's just exhausting, isn't it? That continual needing to prove the health of economic case. And it makes me wonder how we support our commissioners to be bolder, more, and take more risks.
And it's interesting, nobody ever says, can you prove the health economic benefits of sitting in a square room with no window and having people on a 9-month waiting list to come and see you?
Yeah.
That's taken as normal and good, and then you have to prove something else.
Yes, prove that a human-to-human connection around a biopsychosocial model will make a difference. I think we're hearing it really does.
So I've got a few questions. I'm on my phone, not checking Facebook, but I've got. You actually can't know. But there's a whole bunch of questions about just sort of technical questions, sort of rapid fire, quick answers. So one question was, do you have any data about the differences between people that did accept the invitation to come to the community appointment days versus those that didn't? Was there a substantial difference, or do you not know yet?
Oh, that's such a good question. I think the team do, but I don't know what it is right now, so I can follow up.
Yeah,
we have been following, yes, the difference of those.
So that'd be really, if there's anything on that, we can put we can send something out. So that a few people have asked that in the chat. There was another question. Which waiting lists were people on? So these are, were people, for example, already on a long orthopedic waiting list invited, or was this specifically for people on a waiting list for community musculoskeletal?
Yes, it's worked. It's been most successful. We've tried it both with those on the standard physio, or we call it Mars. What's Mars?
Life on.
Yeah, anyway, yeah. So it's worked best with those who haven't had their issue for a very long time. So where we've tried it, where someone is likely to need imaging or an advanced practitioner support, it's more tricky. So it works best with those who need to see a physio.
Okay, and that's helpful, but at the same time, then frees up capacity for people in the services. Then we had a question. Some people it said, oh bless you, some people it said, I need something IP. Some people were asking, some people went on to a patient-initiated follow-up pathway PIFU, or
PIFU, yeah.
we hate that expression, but come back if needed, we like to call it. But not some people, what's PIFU, it has connotations. It sounds a bit like, I won't say what it sounds like, but come back if needed. But some people weren't given that option. So some people said were discharged, and some people were put on a patient-initiated follow-up. What was the difference, or have we misunderstood?
So yes, so around half went to come back if needed, and quite a good chunk of people were made an appointment on the day to see another person in a clinical setting who needed it, and then some were. A small number were discharged. Most people preferred the come back if needed.
Okay, so anybody could opt for come back if needed, or against that? Okay.
Yes, yeah, or there may be people who would need imaging or to see, to have a series of physio sessions, and then they were booked in for those.
Okay, and did you measure? You had collaborate, which is a measure of shared decision making, very, very high scores.
Yes.
And you commented, and I thought, again, Rosemary, thinking about the stuff actually came across in all, that the expertise and how surprised you were to see those very high collaborate scores. Were you measuring patient activation, self-efficacy, anything alongside, and seeing if that changed from beginning to end, or was that something you've not done yet?
No, not done that yet, because essentially we wanted to know about the efficacy of that intervention.
Thank you. I think Beth has got the question here. How long did it take to develop the intervention? Who's this to? I think this is community appointment days. How long did it take to develop the intervention? Do you think other areas looking to replicate a similar process would have to work through? So we've heard some of that from the Peaks folks.
No, we've seen people, it took us 4 or 5 months to work it up, and then we've seen places in other parts of the country do it really quickly, within a few weeks.
Okay, and there's some conversation in the chat. I don't think we need to do this. People might want to go on the chat, people that are in the room, and there's lots of other discussions. There's some discussions going on about data capture and how this can be submitted to NHS England. How might that link to proposed national audit for musculoskeletal services? So we won't chat about that now. There's some questions about how this might link to rheumatology services. Can I ask, do you have rheumatology or orthopedics represented at the days, or is that seen as something not for the day, but something
absolutely.
to go after?
Yes, we have our rheumatological colleagues there too.
Orthopedics as well, or?
We have invited them. They don't always come.
Perhaps they have other things to do as well. Will be kind. Okay, listen, thank you so much. Do go on the chat, even if you're in the room. There's lots of conversation going on. We're going to have a comfort tea, coffee.
Second.
Oh, we're going on.
Yeah, second.
Oh, no break. If you're hoping for a break, it's tough. So we're going to. So I'll take back the risk of causing an outbreak. I'll take back this. So we're going to now head on to some conversation about population health management. Amardeep, you were there before. Can I just check that you're still with us online?
Yeah, I'm still here.
Fantastic. Michael's going to do clever things. So, Amardeep, you're going to talk to us about trajectories of work absence. It's a big topical issue at the moment. I won't use the P for political word given PERDA, but it's a topical issue, let's say, trajectories of work absence in England due to a musculoskeletal condition. And you're an early career researcher with a statistics background, working at the University of Birmingham, working on prediction modelling methodology with an application to machine learning. You've worked on systematic reviews, meta-analyses before, and today we're going to talk about the findings from your PhD, where you were looking at patterns of sickness absence using electronic health records. It's great to have you with us, and I think you're unmuted and good to go.
Yeah, thank you very much, Benjamin. Can I just check, can everyone see my slides okay?
Yep, slides are up and we can hear you loud and clear.
Oh, that's perfect. Thank you so much. Yeah, so I'm here today to talk to you about my PhD, which I've actually just finished. So I just passed my Viva 2 weeks ago, which I'm really pleased about.
Round of applause.
Thank you. So this was conducted at Keele University. My supervisors and co-authors are Professor Gwenwyn Jones, Professor Kelvin Jordan, and Professor Claire Holdsworth. And if I just go into the structure for today, so has that slide changed? Oh, okay, I think it should be changed. Yeah, so the structure is, I'll talk to you a bit about the background of my PhD and the aims of the PhD. And then I'll be focusing on my main study, which was where I derived trajectories of work absence. So these are different patterns of work absence over time. And then I'll just conclude by talking about my final study, which brings the whole PhD together and asks the question, what do people within these trajectories of absence look like? So what are the associations of characteristics with these trajectories? So the background, I think it's already been kind of touched on kind of in the earlier sessions, but my PhD is about long-term sickness absence, which is a topical issue because levels of economic inactivity have hit record levels as of late, and this has been mainly due to people that are on long-term sick. These are just some examples in the media. And we know that the two main reasons for sickness absence in the UK are musculoskeletal conditions and mental health conditions. The good news is that most people do get back to work reasonably quickly after an initial absence, but there's a smaller group of around 1 in 10 people who go on to have longer term absences of more than 12 months. And the way the sickness absence management system in the UK works is that if somebody is off work for more than 7 days, a healthcare professional can issue something called a fit note. This then entitles people to claim sick pay through the state, and these are recorded as electronic healthcare records. So why is this research important? Well, it's because lengthy work absences, they're harmful at all levels. So at the individual level, because we know that being in work is generally good for you, whereas being out of work is associated with poorer mental health and poorer physical health as well. It's bad for employers because they're losing their staff, and the staggering consequences for the wider society, especially in terms of the national economy. But early and greater targeted health and work support, this could encourage a faster and more sustained return to work. So what I hypothesize in my PhD is that recognition of common patterns of work absence over time, so these are trajectories, this might help healthcare professionals to better identify who is at higher risk of long-term sickness absence at the point that somebody first sees their healthcare professional about a sickness absence. So this motivates my PhD aims. So the first one was to derive these common trajectories of sickness absence. The way I did with this was using receipt of fit notes as a proxy for sickness absence. The population I looked at was people that consulted their healthcare professional with either a musculoskeletal or a mental health condition. I'll focus mainly today on the musculoskeletal condition cohort. And then the second aim was, well, I've identified these different patterns of sickness absence. Then I want to know what do the people in those patterns look like. So I assessed different health and sociodemographic characteristics to see which ones were associated, particularly with the longer term absence trajectories. And all throughout my PhD, I used a very large primary care data set called the CPRD-ORM. So to talk about my main study, so this is where I derived these different trajectories of absence. The overall population was people that were economically active in England. So these and people that had also received a first ever fit note from 2016 through to 2018, either due to a musculoskeletal or a mental health condition. The way I then went about defining the trajectories was I used a binary fit note definition. So this was either yes or no. If a fit note was issued for any reason after the index fit note in each time interval. I then tested the effect of using different time intervals. I also played around with looking at different follow-up periods. So this included 1 year follow-up and as well as longer term follow-up of 3 years. And there was also a methodological component to my study where I tried out different statistical techniques to derive these trajectories. And in the end, so through comparing all these different approaches and through discussions with various stakeholders, I decided upon an optimal model, which involved 2 monthly intervals and a 1 year follow-up period. This model contained 5 different trajectory classes, and it was based upon a technique known as latent class growth analysis. So this is kind of the main results of my PhD for the MSK cohort. So this is my optimal model now. It's a 5-class model. You have probability of fit note issuance on the y-axis, and then you have the 2 monthly time intervals on the x-axis going up to 1 year post-index fit note. So what you can see is if we concentrate at the bottom, so the green line, this is the best case scenario for people that first see the healthcare professional about an incident fit note. These are people that just received that first ever sickness absence, so I called them single, and they had a sustained probability of close to 0 all throughout follow-up. So actually most people fell into this category, which was quite reassuring. So around 45% of people just had a single index fit note, and then they had a sustained return to work immediately thereafter. The next most favorable trajectory, so this is the light green line, which I called short term. So this contained kind of around 30% of people, so also a good chunk of the population. Here, people were very likely to receive another fit note after the index fit note within the first 1 to 2 months of that index fit note. But after those first couple of months, most people in that group then returned to work and had a sustained return to work. So it was really just kind of a short-term absence of up to 2 months. And then the third trajectory, so this was kind of in between. This is what I've called intermittent low. So there was 20% of people in this group. This is the blue line, and this was characterized by people that had in and out behavior of sickness absence over time. So most of them experienced 1 or 2 relapses at some stage during that 1 year of follow-up. And the final two trajectories, so these were the least favorable and the ones that I want to focus most on. The first one I've called chronic fast decreasing. So this is this orange line. These actually contained quite a low prevalence, so 2.6% of people in the chronic fast decreasing. These were characterized by people that were continuously off work for the first 6 months of follow-up, and then they returned to work thereafter and had a sustained return to work. Whereas the final trajectory, the chronic sustained, so this is the red line at the top, this is where people were generally off work continuously for the whole of that 12-month follow-up period. So this one was probably the most concerning. So that was my MSK trajectories. Just for comparison, I thought I'd just show you the mental health cohort final trajectories as well. So what you can see is that the final model I chose was actually the same. It was a 5-class model. And not only was it the same, but the shape of those 5 trajectories, if you look at the 2 plots, are pretty much identical. So there was no real difference. And the prevalence as well, so the percentage of people within each of those 5 groups was also similar. So what they showed was that it really didn't matter what the initial reason for that initial incident sickness absence was. The resulting trajectories that ensued in the following 12 months seemed to be quite similar. So just to kind of finish off with my final study, which really now brings everything together. So now I was interested in trying to work out what people look like, particularly in those 2 most severe trajectories. So the chronic sustained, which was the red line at the top, and the chronic fast decreasing, which was the light orange line. So I did some association analysis, and these were my findings. So for the MSK cohort, I found that the people in those 2 most severe absence trajectories, they were more likely to be older, so 46 to 66 years of age, to be from the north or the middle of England, or from the more deprived areas of England. So there was some evidence of some regional inequalities in my results. They were also more likely to be smokers, to have been prescribed opioids, gabapentinoids, or antidepressants in the 2 years before their index fit note. And they were also more likely to have more MSK consultations in the 2 years before their index fit note. And then in terms of the type of MSK that they had at baseline, I saw it was mostly people that had baseline knee pain, osteoarthritis, or baseline hip pain. So that was the MSK associations. Just for comparison, I've included the mental health cohort associations as well here. So the first 5, which are put in bold, these were actually common for the MSK and the mental health cohort. And the only slight difference was that the mental health cohort was slightly younger. So people that were 36 instead of 46, they were actually more likely to be in these longer term absence trajectories. Also, males came out as significant. So males were more likely to end up in these 2 more severe absence trajectories, as well as people with either baseline anxiety alone, baseline depression alone, or baseline anxiety and depression combined. People who were obese or had a not recorded BMI status were also more likely to end up in these longer term absence trajectories, as were people who had excessive polypharmacy. So this is people that were prescribed more than or equal to 10 drugs in the 2 years before the index fit notes. So just to wrap up, so the main conclusions of my PhD was that I identified these 5 different trajectories of sickness absence, either due to a musculoskeletal or a mental health condition. And then I looked at, and then I identified this profile of people that were associated, particularly with longer term sickness absence. This is useful because it provides, for example, the government useful evidence to be able to target some of their upcoming initiatives, such as the Workwell pilot and the FitNote reform, to make sure that these pilots are being targeted at the people that need the support the most. There was also evidence in my results of health inequality. So I kind of mentioned that there were some regional inequalities where people from the north or the middle or the most deprived areas of England were more likely to end up on longer term sickness absence trajectories. So this just kind of further reiterates the need to reduce health inequalities generally in England. And I also advocate that wider actions are also really important to improve employer engagement in return to work management. This was a key theme that came up in a PPIE session that I ran as well throughout my at the end of my PhD. Thank you very much. These are just some acknowledgements. Thank you. Let's stop sharing.
Thank you so much. So be holding on to questions. And yeah, great to see you there, Marta. That was my next question. Are you there? So that's fantastic. So hang on to questions if you're in the room or put them in the chat. Lots of questions coming in about peaks. I don't know if anybody from peaks wants to log on to the chat and be answering some of the questions, but the Teams chat is ongoing with lots of questions for you guys, or for you folks, we should say. Right, so classification of patients with osteoarthritis through clusters of comorbidities. So rather like in the last talk, we heard about how there were different clusters, if that's the right word to use, but different groups of people with particular patterns. And if you knew that and were able to identify which pattern someone was in, well, you might be able to provide a smarter intervention. And this builds on a lot of work that's gone on in musculoskeletal health. For example, the START back tool and the START MSK tools, which are about trying to classify or categorize people. That all sounds a bit Harry Potter sorting hat, but trying to identify people who are likely to have particular outcomes. And so we can tailor the offer to that group. So we're now going to hear about classification of patients with osteoarthritis. And this is from Marta, who is online. Marta's a biotechnologist by background and an epidemiologist by training. She conducted a PhD at the University of Barcelona, and you've been a postdoc at Oxford for the last 3 years. You've been involved in multiple projects, including musculoskeletal conditions, COVID-19, inequalities and outcomes amongst people from different ethnic groups in the United Kingdom. I absolutely loved this work when I saw it, and I'm so pleased that we've been able to hear from you today. So Marta, over to you.
Thank you very much. Can I just verify you can hear me correctly and that you can see my slides as well?
Yes, both are true.
Perfect. First of all, thank you very much for the kind introduction and also for giving me the opportunity today to present this work we conduct. That, as it says, just like we try to see if there were like patterns of clusters in patients with osteoarthritis. Probably most of you are even more familiar with me with this condition, but just very briefly, osteoarthritis basically is a deterioration of the joints that most cases will require a joint replacement. And to just increase the burden of the patients, those who had osteoarthritis are also more likely to present other concomitant conditions that we call them comorbidities. And these comorbidities exacerbates the pain and diminish the physical function even more. So that's what that's what brings us to just try to identify different types of patterns of comorbidities in these patients. So we could just detect those who might require extra healthcare attention. So to do so, we use a primary care database from Spain that it's called CDAP. We include anyone who was 18 years or older with an incident diagnosis of OA. So we aim to capture them the first time that osteoarthritis was diagnosed. And we also require at least 1 year of clinical history. So we were sure that potentially we were capturing most of them when they had this incident diagnosis, but also that we had enough clinical history to capture the different comorbidities. So the methodology we focus is the cluster analysis. For those of you who might not be familiar with cluster analysis, it's a type of multivariate technique that it's in the machine learning area that basically aims to group or categorize a set of observations or data points, or in our case, patients with osteoarthritis. So the idea is that you just will find different groups in your bunch of patients. The challenge of cluster analysis is that you at the beginning do not know how many groups the data can be explained or distributed. So one of the things you can do is basically use more than one algorithm, and that's what we did. So we use k-means and latent class analysis. Given the amount of time that I have today, I will just focus on the results that we decided was the best or the best models. But just to let you aware that if you want to have a deeper look into that, this is very much explained in our publication. So for those of you, again, who are not familiar with latent class analysis, the benefit of this model is that it gives us the probability of the patients to belong to each of the clusters. And that can be very useful when we try to model which are these associations between comorbidities. So we include more than 3,000 individuals, and we initially start with a bunch of 58 different comorbidities that were selected by clinicians for the literature that were associated with osteoarthritis. However, we did the first cleaning of those comorbidities that were not very common in our patients. And we end up finally including 36 that are the ones that you can see in these tables. So when I'm talking about these comorbidities are the ones that were included in the latent class analysis model. And this is basically the main result where we think it's the best, potentially the best model and how you would ideally try to identify different types of clusters. The order of the clusters, it's irrelevant. It's just the way the software gives you the answer back. But the thing that we did here is we tried to find some labels to identify quicker what we were observing. So to understand these plots, basically you have all the comorbidities in the bottom, and then you have the prevalence of these comorbidities in the patients for the specific cluster. These horizontal black lines basically are the prevalence of the patients before we stratify them into the different groups. So we use it as the average before this stratification as a sort of comparison. So what we start here to do is see which conditions, which comorbidities were higher than this average. So if we start, for example, for the red cluster in the bottom, we saw that basically patients in this cluster number 4 had higher prevalence of hypertension, diabetes, and obesity. And if you're a clinician, you might think very quickly, oh, this is metabolic syndrome. So the next one, we can focus, for example, in the first cluster. And we saw that most of the patients had back and neck pain, but also there was a high prevalence of anxiety and depression. So we thought, okay, just name it as back and neck pain plus mental health. The next cluster we can focus, for example, is this third one, the blue one. You can see here that in this case, the prevalence of all the comorbidities are lower than the average. So we call this cluster as the healthier cluster. We call it healthy and not healthy because these patients at least have osteoarthritis, but they look like they might be healthier than the other clusters. And when we compare with this latest cluster here in purple, we see the opposite. So in this group of patients, we saw that all the prevalence of all the comorbidities are actually higher than before the stratification. So we call them as the multimorbidity cluster because most of them have more than 2 even comorbidities concomitant with the OA. So the next step we did basically was trying to validate these clusters with external data. And in this case, what we can do in cluster analysis is see variables that were not included in the model. So we try to see if these clusters make sense clinically. So if we start with the metabolic syndrome cluster, which is in red, here we can see that the colors also match the panel on the B panel. So you can see basically those who had the metabolic syndrome had the higher prevalence of men. So, and at the same time, they are the ones who present the higher BMI. So it makes sense at the moment. Then we also saw, for example, that the healthier cluster, they are the ones who had the lowest BMI, and also that they had less current, I think it's smoker, no drinkers. So it looks also like, okay, maybe it makes sense. Then we also saw that the multimorbidity cluster were those who were the older. So the next step was we wanted to do a further validation even. And what we did basically is include some outcome that was clinically relevant. And in this case, we include mortality. So we compare mortality at 10 years with these 4 clusters we find out. And we use the healthier as the reference. And we quickly see that basically those who had the multimorbidity, those who had much higher prevalence of all of the comorbidities had even twice the risk, or even more than twice the risk than the healthier cluster. So in addition of that, these clusters clinically might make sense. It can be useful to identify which patients could belong to which when they are identified for first time with osteoarthritis. We also know that perhaps we are only capturing them because we have a static picture. We might only see different type of progressions of osteoarthritis, and we know this is a limitation of our study. However, this is still relevant that when we identify the patients in one of these 4 clusters, we can have a better care for them, especially for the multimorbidity group. And I also would like to mention that this was part of a bigger study that it was called the COMOA study. So this same analysis was replicated independently in 3 other European databases. And the beauty of this repetition is that we actually saw the same 4 clusters across the whole this whole databases, with the slightly difference that the metabolic syndrome cluster, it was more like a cardiometabolic group in the other 3. So once again, if you just like want to know a bit more about this analysis and perhaps also see where the other clusters with the other methodologies or how we just went through, please have a look. And I'll be happy to also like discuss further, even if it's offline or here. Thank you.
Okay, that's fantastic. 2 really fantastic presentations, and thanks so much, Martin. I'm going to hand the microphone now. We'll see how let's see how you go. So I'm just going to start. I mean, an observation I made thinking about both of those presentations is that quite often we look at the conditions as the thing that need to be treated, osteoarthritis, let's say, rather than the people who need to be supported. And I mean, versatile arthritis folks may want to, I mean, I'm a versatile arthritis folk, but other versatile arthritis folks may want to comment on what some of this tells us about our service provision. That for me, having those 4 very distinct groups of people with very different time courses, and Amandeep, it must link in to the work you're doing as well. It's, you know, sort of this younger, slightly more female mental health more widespread pain, an older male group who have what we call metabolic syndrome, body unable to handle and process food in a healthy way. So people getting type 2 diabetes, high blood pressure, heart disease, gout, all goes with that. And then you've got this older group with a great deal of multimorbidity who have the highest mortality associated. And there's some papers recently. I was just seeing if Ross Wilkie's on the chat, but I don't. Do we have Ross? I don't think Ross was there. But Ross recently published something sort of looking particularly at how with osteoarthritis of the knee in particular, and it's the fact that your mobility and you're not walking, that seems to be the main mediator behind the mortality. So, then we start to think about the physical activity dimensions. So it's different across the group. And then you've got a younger, inverted commas, healthier group of people that happen to have osteoarthritis of a joint, but don't have the other problems. And I'm thinking about these very 4 distinct groups of people, and this may link to things that are going on in community appointment days. What support do they need as a person, as opposed to what is the treatment of osteoarthritis? It's a very different mindset. And health services at the moment are really still largely set up about treating diseases. And I'm not a researcher, researchers may ought to comment, but it strikes me that a lot of research is focusing on treating the diseases as opposed to identifying groups of people who need different types of support because their health and work trajectories might be, their health trajectories are different based on other things that are going on. Amity, can I ask you, just while I'm gathering some questions online, can you comment on, I mean, you may well have known Marta's work, but can you comment on how that links with the work and your findings and those trajectories?
Yeah, sure. Yeah, I think that's a really good point. That was definitely something that came up from a PPIA session that I ran as well. So I ran a session with people that had lived experience of sickness absence, either due to MSK or mental health conditions. And one of the key things that they kept saying was that it's not about treating the health condition. That's not what helps them get back to work. It's a much more holistic intervention that people are looking for that deals with their psychosocial barriers. So that's kind of what I really did what I really did advocate at the end of my thesis was that what's needed next is an intervention that not just treats MSK or mental health, but it works out what exactly is stopping these people from getting back to work. And I think it links to some of the discussions that were mentioned earlier. It's about, for example, the deprivational and regional inequalities that I saw. What we probably need is improved access to jobs in the north of England to reduce debt levels and reduce stress levels. So there's a kind of multifaceted combination of factors that are at play. It's what I really want to advocate is it's not really just a health condition. That's kind of a small part of the overall picture.
That's great, Amadou. Thank you. We've got a question in the room. Let me just hand the microphone over.
Yeah, no, it was more just a comment. So as part of another study, we did a national survey of people's priorities for care across a broad range of rheumatic and musculoskeletal conditions. And again, that's what came out. It was younger people, younger women in particular, who really felt that their priorities for care were not being met. And it was particularly things around what stopped them accessing the services and support that they needed. It wasn't always the fact that they weren't there, although sometimes that was an issue. It was the fact that information wasn't given to them in a way that was meaningful to them or in a timely way. And also caring responsibilities came out consistently and across the age groups as being a barrier to accessing services. So we do have some information on some of those things, but signposting and having information in a way that was meaningful to them was really lacking, as well as work support as well.
That's great. Karen had a question in the chat, and I might bring the microphone to you in a moment, Karen. But Jackie, I was just wondering if you might unmute Jackie Clinch, that you've made, sorry, got you mid-slurp, but you made a few comments about children and young people, a bit of the discussion. I just wondered if you wanted to come in with a comment or a question about that.
Yeah, sure. I've just got a mouthful of nuts. You've caught me with, Ben. Yeah, I mean, we know, for those of you that don't know me, I'm a paediatric rheumatologist and just demitted from the BSR yesterday as vice president. But my big kind of area of interest is non-inflammatory MSK pain in young people going on into young adulthood. I think what we've noticed clinically, certainly within our pain services, but also within our rheumatology services, is there been a complete explosion of young people coming with non-inflammatory MSK pains, often late to us, often with significant mental health needs. And so I think the PhD work showing that very clearly almost identical graphs is what we see at the coalface. I guess I'm wondering a question. I think we're collecting great data. Kate's team will present some of the primary care data later on this session. It's how we move forward together for strategies to get in earlier and getting meaningfully and insightfully into this group. And we are really data poor. We absolutely know what's happening, but when it comes to data, we haven't got the fantastic stuff you have in the older adult groups. So I guess, how do we collect this? How do we measure school absence? It seems extraordinarily difficult. And the impact on young people transitioning into the workplace or further education. A lot of the young people are starting further education and then coming away from that, leaving after their first year of college or uni with persistent MSK pains and mental health needs. It's an absolutely, it's a tsunami. I can't underestimate it.
Thank you. I'm going to ask Karen to ask a question, and then Jane, thank you. I'd like to bring you in talking about this explosion. Explosion might not be the right word, but this massive increase in people, young people in particular, with pain and mental health difficulties. But Karen first.
Hi, so the comment that I put in the chat was just around that sort of the similarities of the profiles of people being so similar between the MSK and the mental health conditions. And it's thinking about kind of people being off work due to their health. There's how much of that is to do with their general health. Lots of people have multiple conditions. There's a big overlap between mental health and MSK. Is it about general health, or is it something specific about the condition? And then also the work opportunities. I think I often think, so I live in Wales, and if we're thinking about kind of work in the valleys and the work opportunities that are available, the expectation of what good health is and the expectation and understanding of what support services there are, it's really different in different places. So if we see these really similar profiles between two different conditions, what does that tell us we should be doing?
So I'm going to over to you on that, and Martin, if you want to comment as well, you're very welcome. But let's hear from our presenters for a moment.
Yeah, so Karen, about the MSK and the mental health trajectories being similar, I think it's a really good point, is that it was actually one of the limitations of my study was that I had to infer the reason for work absence because I couldn't get this directly from the fit notes. And I think it is the case that a lot of the people, for example, that in the MSK cohort could have actually had a mental health condition at the beginning as well. So there's a massive overlap. It wasn't necessarily seen in the data, I think, just because of the way that I defined it. So I think probably that could explain why we see such similarities. It was also seen, because I did a systematic review where I looked at other studies across the world that had looked at similar things, the trajectories of absence due to MSK and mental health. And they also found that there was no real difference in those trajectory groups for the MSK versus the mental health.
Martin, what do you make of that, and how does that link to your clustering work?
So one of the things we find that on the way to finding which were this final cluster solution is the other method we use, it's K-means, actually differentiated for the way it works in the background between patients who had back and neck pain and then the mental health, like the higher prevalence of anxiety. We actually select this latent class model because it was able to highlight that actually back and neck pain plus anxiety and depression were together in the hand, very, very close. And it makes sense that if you're physically impaired by basically you may just like have a hard time moving, walking, your mental health might be affected highly. I could even just like think and relate with patients on that. So it was one of the main reasons why we see this is probably what makes much more sense clinically to identify on patients and try to see what we can do then for them.
So we have this thing, and we have this links to what we heard earlier from Peaks and also from the CAD days, that this interplay between physical health, particularly chronic pain, and mental health, that the chronic pain worsens your mental health and having poor mental health worsens your chronic pain, and actually addressing both of these and treating people as individuals. We're going to just do 3 comments, and then we'll finish off with Amandeep and Marta again. So we had one question here, Amandeep, which was, what do you think are the top 3 most impactful areas to focus on to improve the work absence position? If you get this right, there might be a job for you in late July. And second of all, there was a question which came in, what was the issue of caring responsibilities? Was the issue of caring responsibilities more important for women than for men? So both of those. And then I want Jane Green kindly offered to unmute just to either comment or ask any questions, just thinking about some of the issues that have come up as well.
Yeah, thank you, Ben. So the top 3 most impactful areas.
Just hang on a moment. Let's hear from Jane with the 3rd point, and then we'll take them all in a round. Sorry, Jane, if you wanted to comment or say anything.
I agree with the interplay between physical and mental. That's what our charity is about, and our experiences. And we have 12,000 members now, definitely, but also the intergenerational issues, because they are heritable. And so we find we're also carers. We're sandwich carers. So we're looking after older people who've probably never had that understanding or diagnosis or support, and then the younger children. And so that is all more pressure. So it must accumulate. So I think I'm very glad caring's in there along with health, and very much the holistic person. I was wondering about 2 things. You mentioned mental health, anxiety and depression, but we know with, for instance, symptomatic hypermobility, which is our issues, umbrella-like, anxiety can be physical. And so maybe there's a disconnect there still, I think. But also with long COVID, I wonder if that was in any of your data. I don't know if it has been, but has that been an issue? Why the younger people, for instance, you're getting more younger people coming with that now? I suppose that's my question.
Oh no, sorry, I didn't mean to cut. Sorry about that. Okay. So why don't we hear from Amandeep, and then last word to Marta, and then we'll take ourselves a break.
Okay, yeah. Do you want me to answer both?
You can answer as many of the questions as you like.
Okay. Yeah. Okay. To go back to the one about the top 3. I mean that's I think that would be like the $1 million question, I guess. I think so. What I really advocate at the end of my PhD as further research, the top priority that I would say is to do a qualitative study. So what I did was a quantitative study, but I think we don't fully understand what kinds of psychosocial barriers are stopping these people. In the profile of people that I identified are people who are at higher risk of longer term sickness absence. We don't know exactly what's causing them not to return to work. So I think doing a qualitative study that follows this group up over time and asks them, that would hopefully help identify how we can best help them back into work. To answer Jane's question, so about the link between caring responsibilities, did you say? Sorry.
Yeah, that was one question. Yes, the caring responsibilities.
Yeah, I think that's interesting. I can definitely see how that potentially could have an impact. It's not really something we looked at because I didn't have the data to see that. In terms of COVID, I think that would be interesting, but the data that I looked at went up to the end of 2021, so it kind of overlapped a little bit, but so it started from 2016 to 2018, and then I used the 3-year follow-up. So it might have been people at the end of 2018, might have had up to 2021, but it didn't really overlap too much. So that's also, I think, an area for further research.
Marta, last word to you.
Just on comment about the COVID, especially long COVID impact. Our research also didn't include the COVID pandemic. However, further research done in the group also did some cluster analysis on COVID patients. And one of the difficulties that was there is that since we know long COVID has a very severe musculoskeletal comorbidities associated, we do not know sometimes when patients were just they already had these conditions before they had COVID, or whether they were part of the long COVID. And it's been really challenging to find different clusters in case of the patients with long COVID because of like the poor recording of these conditions before.
Great, thank you. We could go on for a long time, but tea awaits, and if you're at home, tea may await. So I think the plan is to be back, and to be back just before and to start at 10:02. So we'll have a little break. The chat can keep going, of course. And thank you to all our presenters. I think a round of applause, and also for the great questions. And see you back in just over some minutes, just over 20 minutes. Okay.
Start coming back. Those are mine as well. Hi, so I'm Karen. I'm the head of health intelligence here at Versus Arthritis. So I'll be chairing the next segment that we've got. To kick us off, we're just going to start with 10 minutes or so from Frank Marks, who's the Director of Welfare at the Nuffield Foundation, and Anna Durrans, who's in the room, who's a Research Programme Manager at Versus Arthritis. And they're going to talk a little bit about some research calls. Anna, do you want to come up? Yeah. And then I can see Mark online. Okay.
Thank you, Mark. Okay, well, thank you for allowing me to speak. So to introduce myself, I'm Mark Franks. I'm the Director of Welfare at the Nuffield Foundation. The Nuffield Foundation funds research to improve people's lives across 3 domains of education, justice and welfare. I'm responsible for the latter of those domains, which is concerned quite broadly with individual and societal well-being, with a particular but not exclusive focus on the labour market and the family. So we administer a large number of grants relating to those priorities, and the Oliver Bird Fund is one of those specifically. Now, I think I have to ask for the slides to be moved along. Could we move to the next one? Thank you. The Oliver Bird Fund, as I say, is a distinct fund managed by the Nuffield Foundation. It's a legacy from Captain Oliver Bird from 1948. He is the bird of Bird's custard fame. And we have, from that fund, found that we can allocate £12.5 million over 10 years to research to improve the lives of people living with arthritis and musculoskeletal conditions. And we've been running that fund for a few years now, and we've done 2 rounds of funding supporting 12 projects. And indeed, findings are starting to emerge from those earlier funds, earlier rounds. For example, findings relating to the potential integration of local data sets, which are projects led by George Peat and Will Dixon, Rosemary Hollick's work on the impact of rural living, and Alan Silman's work on decision making for those facing surgery. And all of those projects have been presented previously to this group. More recently, we've started to focus more on social and economic well-being in a way that aligns with the broader aims of our welfare domain, which I was talking about a moment ago. So looking beyond the health service and clinical settings, and supporting a number of projects related particularly to working lives. So Holly Blake in Nottingham is exploring the feasibility and acceptability of the Pain at Work toolkit. Ross Wilkie at Keele is extending the measure of healthy working life expectancy for people with MSK conditions, and there are various other projects as well. And I'm sure this group will be seeing some of the findings from that research as it continues. Could you move to the next slide, please? Thank you. We are launching a new call. What I should say is I think my colleague Catherine Dennison has presented to this group before, and she's really, for Nuffield, the powerhouse behind this fund. I'm filling in for her today, but she has really taken this forward from the beginning. And the other big acknowledgement that needs to be made is for Versus Arthritis, who have worked with us since we relaunched the fund in 2019, but increasingly so, and certainly at an increasing scale. But Anna, who's going to be speaking in a moment about a different call, I believe, has been absolutely essential to us in terms of working on this one. So I'm particularly grateful to her, but to everyone at Versus Arthritis for helping to make this collaboration possible. And the £6 million worth of funds available in this call. And we're looking potentially for awards up to £750,000 and for projects up to 4 years. But we would consider going beyond that if the proposal was exciting enough and innovative enough and offered sufficiently good value for money. So obviously, the larger the grant, the more convinced we need to be on those aspects. But we are definitely open to big and ambitious ideas that speak to the priorities set out in the call. And just to say a little about what those priorities are. One of them is around the wider determinants that can contribute to enabling individuals to live with their condition and optimise their quality of life. And so this may involve considering how support from family, school, work and social networks and communities and public services can enable an individual to manage their condition and participate in activities that are important to them. And relevant areas of focus include participation in education and training, participation in work and achieving economic security, housing, transport, planning, experience with the welfare and benefit system, family life, participation in leisure and community involvement, and support from formal and informal care. So a very broad set of interests. And indeed, that's not mutually exclusive. If there are other potential interests that speak to the broader aims of the call, we are interested in those. One of the other projects that is funded from my area at the Nuffield Foundation is the Deaton Review of Inequalities, which some of you may have encountered. And we have a broad interest in inequalities in all of its aspects. And so work which speaks to those issues is of particular interest to us as well. Crucially, projects do need to have a potential for policy and practice impact. That's something we will be looking closely for in the work we support. And indeed, that's something that relates to all of the foundation's funded research. Next slide, please. So I just wanted to say a little about the process for applying. We've got this quite nifty dinosaur QR code. It will work, I think, for people at home because I've tried it on my phone. It works for me. Whether it will work in the room, I don't know. But all it does is take you to the website, which is on that slide, and I'll put that into the chat in a moment as well. So that's where you can go for full details of the fund and the criteria and the process for applying. Applications are due by the 16th of September, and as previously, there will be a two-stage process. So an initial outline expressing interest and providing a broad plan for the work, followed by, for those that are shortlisted, a full application in January. Then we will convene an expert panel in April to make the final funding decisions. I should say that reviewers with lived experience of MSK conditions will be involved throughout this process. So we actually look for a lived experience component in the applications that come to us, and we also involve people with lived experience in the assessment process as well. And that's just one of the areas where collaboration with Versus Arthritis has really helped us to learn how to do that effectively. Projects can start in July 2025, and as well as the website, there is a contact email address there as well. I will remain in the meeting and very happy to try and answer any questions that go into the chat. I don't think there's time for Q&A in the agenda. It doesn't look like it, but if anyone wants to put any questions into the chat, and they're relatively straightforward ones, I might be able to answer them. But really, if you want a detailed response, I'd recommend, first of all, looking at the guidance on that link, and then if you contact that email address, we will look at that and get back to you. But thank you very much, and I hope there's a lot of interest in the call.
Thank you, Mark. Okay, so just to say we're really, really happy to be partnering again with the Nuffield Foundation. It's been fantastic so far. We're starting to see some of the information that's coming out of the projects that have been funded. Really excited that there's going to be more hopefully in the pipeline, so it's brilliant. I'm just going to talk to you about some funding opportunities from Versus Arthritis. So we have 4 areas of research priority: early detection and prevention, targeted treatments, living well, and then a sort of overarching people and partnerships theme, which ensures we're working with the right people. It's the Nuffield Foundation on everything we do. So the Oliver Bird Fund falls under our Living Well research priority area, as does our new call, confusingly, but it's a new call funded just by Versus Arthritis alone, called Living Well 2025. There are similarities with the Oliver Bird Fund, so they both address health inequalities across the life course, and we're interested in ensuring that people live well with their conditions. The main difference is that with the Living Well Versus Arthritis call, we're interested in focusing on services that are delivered by health and care professionals, so within the healthcare services. So we're looking at a research which will improve access to and delivery of healthcare services. We want to see improved service delivery for communities with less access to healthcare. We've heard a lot of research this morning where this is shown to be so important. All of the areas that we're covering this call are so important. We would support innovative ways of enabling access to healthcare, as well as the evidence for effectiveness of existing models of healthcare access. We want to look to improve healthcare service pathways, understanding the current experience that people have going through healthcare pathways, identifying what good looks like, and finding ways to improve joined-up care. We're particularly interested in osteoarthritis, osteoporosis, and gout, but that's not to the exclusion of other conditions. Lots more information on our website, so I'm just giving you the highlights here. We also, as has been mentioned in all the talks this morning, we want to take a holistic approach, patient-focused approaches to understand the best ways to access and move through health services, focusing on symptoms and the experiences that people have of the health services. And we want to improve the interactions of people with arthritis and healthcare professionals. So that takes into account all the different reasons why people have different levels of health literacy, and that will empower people with arthritis in their interactions with healthcare professionals. And we want to improve the ability of healthcare professionals to provide evidence-based support, something else that we've heard mentioned this morning, ensuring that health services are informed by the right kind of health data and knowledge. And as I said, we've got cross-cutting themes across everything we're doing, actually, health inequalities across the life course. We are interested in the transition from paediatric and adolescent to adult care, huge area that's not got enough information and data, as Jackie was saying. And we want to make sure any of the data coming out of research is relevant across the 4 nations. So it doesn't mean that you have to have researchers in the 4 nations, but anything you're doing needs to be applicable, or you need to understand how it could be applicable in the devolved nations with their different healthcare systems. So we are offering 400,000 to $1 million in funding for up to 3 years. We expect to make a smaller number of larger awards, hoping to make a bigger impact in this area. There's a deadline of the 11th of September. It's, bless you, it's a 1-stage application process, and there'll be a funding decision in March of next year. So, sorry, that's walking through that one. So there's more information on our website. There's more I'd go through, but I think I want to move forward in the interest of time. We've also got a call which is following on from 2 previous calls under early detection and targeted treatments, addressing those priority areas of our research strategy. to bigger consortium calls focusing on clinical epidemiology and inflammatory arthritis. Lots more information on our website. I'll be around at lunchtime if you want to ask more questions. Those are open at the moment to emails, expressions of interests, which are just short summaries of what you want to be doing and a list of the people that need to be involved. But again, more information on the website. And then we have some smaller fellowship awards and that's 5-side, right-side network as well. Small grants on our website as well. So I also developed a QR code because I saw Catherine done one and it doesn't have a dinosaur. So that's where all the information is. Feel free to get in touch.
Thank you. And exciting to see what is coming down the line, and hopefully we'll be seeing this group and other similar groups in the future. If you've got questions, stick them in the chat for that, and that will mark. So the next section, we're going to be talking about epidemiology of musculoskeletal conditions and chronic pain. So we've got 3 speakers. The first is Katie Mason. So she's a research fellow from epidemiology and biostatistics at Keele University. Her research uses electronic health records in primary care to understand prognosis of common health conditions such as musculoskeletal pain. She's lead analyst for the quantitative work package in the NIHR and Versus Arthritis funded programme Campaign. I've just got the campaign, nice, which is investigating musculoskeletal pain with children and young people. So highlighting something Anna pointed to. So children and young people, the data recorded in primary care, and that's what she's going to talk about today. As in the previous sessions, please encourage you to contribute thoughts and comments into the chat, and we'll have a discussion at the end of this for you. So I think I need to start with good afternoon, everyone. We've just tipped over after midday. Thank you for inviting me to present today. I'm really excited to share some of our findings from the campaign programme grant. So I'm just going to go into our background. Musculoskeletal pain, as everybody in the room is going to be aware of, is very common. It's often recurrent or persistent and is a leading cause of disability worldwide. There's evidence that pain in childhood is related to musculoskeletal pain among adults, but the evidence base is scarce in children and young people. The Scottish Government's 2018 Child and Adolescent Chronic Pain Management Guideline concluded that high quality evidence is needed in all areas of paediatric chronic pain, with research on non-chronic musculoskeletal pain rarer still. The evidence gap is most acute in primary care settings, and there's currently no NICE guidance on treating musculoskeletal pain in children and young people, whereas guidelines for back pain and for chronic pain exclude those who are under 16. There are also differences in consultation patterns between children and adults in the literature, meaning it's inappropriate for us to just simply apply findings from adults to the younger population. So that's where campaign comes in. And within campaign, we've got 4 work packages with the aim of better understanding musculoskeletal pain in children and young people consulting within primary care. And as in the introduction, I'm the lead analyst for work package 1, where we're focusing on the epidemiology and management of children and young people. And today I'm going to focus on our first 2 objectives, which is around consultation prevalence and the management of musculoskeletal pain within primary care, in the hope that you might have us back to talk to you a bit more about prognostic factors and healthcare costs when we've done those analyses. So our primary care data comes from the Clinical Practice Research Data Link, or CPRD Forum. This is a national primary care database that's generalisable in terms of population distribution and currently has coverage of 20% of the English population. Our inclusion criteria for the study were children and young people who were aged 8 to 18 years old at the time of a consultation for musculoskeletal pain in primary care, recorded between 2005 and 2021. Our definition of musculoskeletal pain was intentionally broad, including painful body sites recorded in primary care, as well as acute codes for sprains, strains and injuries, and chronic codes including diagnoses. Today, I'm focusing on the 5 most prevalent body sites, which are the back,
chest or trunk, foot or ankle, hand or wrist, and the knee. In our analysis, we identified 1.67 million children and young people who were recorded in primary care that met our inclusion criteria. In terms of demographics, just over half were male, and that there was a median age of 13 years. And we had a consultation prevalence of around 9%. So I'm just going to take you through a bit more detail around our consultation prevalence calculations. Here we've got it presented over time by age and by gender. We've got females in green and males in orange. And our age bands were actually suggested by our Young Persons Advisory Group, who have been really pivotal in the work that we've done so far. They tied in the progression from primary school to the first age band, so around the ages 11 to 12, and in leaving secondary school or becoming more independent at ages 15 to 16. In terms of the trends on the graph, we see that the consultation prevalence generally increased until 2015, stabilised until 2019, was lower in 2020 due to the pandemic, and climbed again slightly in 2021. And that overall, particularly from 2009 onwards, females had a higher consultation prevalence than males within each age band. In our next graph, we've looked at the 5 most common pain sites by age in years and by gender as well. This time, the youngest age group are shown in shades of orange, that's 8 to 11. The middle age group shown in shades of blue, which is 12 to 15, and the oldest age group shown in shades of green, 16 to 18. So just wanted to highlight that foot and ankle pain, particularly in those younger children, is doubly as common as any other pain site in that age, which was quite an interesting finding for us. Then looking across the other pain sites, we find that knee pain becomes pretty much equally as common in 13 to 14-year-olds. And then for back pain, we find that in 17 and 18-year-old females, the rate's almost double that of males of the same age. So quite a few gender and pain site differences. So in summary, for objective 1, we determined that musculoskeletal pain is common in children and young people, with almost 10% consulting primary care every year. We observed variation by age and gender and body sites consulted for, with younger children consulting for foot and ankle pain, older females consulting for back pain, and knee pain being equally as common in the middle-aged children. Just to also note, we have also looked at consultation incidents, but repeat consultation was uncommon, so I haven't presented those trends as they just look exactly the same, just a little bit lower. So moving on to management, we restricted our initial sample to those with an incident consultation for musculoskeletal pain. So this isn't true incidents. We've omitted anyone who had a musculoskeletal pain consultation in the previous 12 months. So this is what we're terming like a new episode of musculoskeletal pain. Due to our large population size from our earlier feasibility counts and work on consultation prevalence, we took a random sample of 25,000 children and young people per calendar year to give us a sample size of 425,000. Our outcomes included referrals to secondary care, imaging or analgesia prescribed either on the index date, which is that first primary care consultation for musculoskeletal pain, or within the next 6 months. We looked at the management patterns by age, gender, ethnicity, region, pain site and deprivation, both descriptively and using statistical modelling. And just for time today, I'm going to focus on the analgesia prescribing. So as shown before, that's our total sample size, proportion that are male and median age. And just to show that the distributions of the random sample were identical, and also we looked across the pain site distributions and they were also identical. In terms of the outcomes, just over half of our sample were recorded with at least one of our outcomes, and just under a quarter were prescribed analgesia within our 6-month time window. So in this graph, it shows overall analgesia prescribing by age, gender and pain site, with females again in green and males in orange. And what we see consistently across pain sites is that there's a greater of the 16 to 18-year-olds being prescribed analgesia than the younger age groups, which is reassuring. apart from foot and ankle, where there doesn't seem to be much of an age effect for males. Overall, older females had the greatest prescribing for back, chest and trunk, and knee pain, and this was most commonly for NSAIDs, or what we're terming basic analgesia, which is essentially paracetamol. We've also looked at deprivation, and in this graph, the lightest shade represents the least deprived and the darkest shade represents the most deprived. And we see that there is increased prescribing within each of our analgesia categories for those who are in the more deprived areas. I just wanted to say that we've ranked this based on the strength of analgesia. So if you were prescribed gabapentinoids or amitriptyline, you only occur in that part of the graph. So in order to be in the basic analgesia part of the graph, you can't have been prescribed any of the other 5. So it does show that most of the prescriptions are for NSAIDs and for basic analgesia. But that being said, we also think that while there are going to be health inequalities, this might actually be driven by the fact that there are free prescriptions in England, and some people might still need to have free prescriptions for NSAIDs and basic analgesia, and trying to unpick that is going to be quite complex within the data. And then slightly more reassuringly, again, focusing in on back pain, analgesia prescribing, the overall trend is that over time, all prescribing is going down. So in the previous graph showing that the more deprived patients are getting more analgesia, it's really gone from being around 30% for basic down to almost 5% overall in the post-pandemic period. So in summary, the management for musculoskeletal pain in primary care also differs by age, gender, and body site. Prescribing is greatest in older females for back, chest, trunk, and knee pain, and a high percentage of the most deprived children and young people who are prescribed analgesia, but we believe this is related to free prescriptions. So in conclusion, having a better understanding of how common musculoskeletal pain is in children and young people, we think can help inform strategies for care and underpin much needed intervention studies, with the aim of reducing risk of musculoskeletal pain continuing into adulthood. We're also quite heavily in the planning phase of a replication study using data from Skåne County in Lund in Sweden, where they have around 160,000 children and young people with both primary and secondary care data since 1998. So we're going to replicate our analyses from our first 3 objectives within that data set, investigate other prognostic factors that are available in Sweden, such as school attendance and entry into the labour market. Lastly, I wanted to end on an image we developed with our Young Persons Advisory Group to try and better explain some of our findings. And that in a class of 30, there will be 3 children every single year that will go and visit their doctor for joint or muscle pain. And just to say that the coloured-in children are aligned with our most prevalent pain sites. So in the first slide, one of the first slides, green's foot and ankle, pink's back, and purple's knee pain. So thank you very much for your attention. And I'll be happy to take any questions in the Q&A session.
Wonderful, thank you very much. I was just going to flag, there was one quick question about being able to distinguish between referrals to secondary care and community services. Do you want to answer that one quickly?
So we develop code lists, and so I know that we haven't got any community care code lists, I'm afraid, that we've used in this analysis. The referral destinations are physiotherapy, orthopaedics, rheumatology, musculoskeletal pain services, pain clinics, and any paediatric services.
Thank you, and we might come back to that in the Q&A. So next we've got Anne Raymond. So she is an economist from the Health Foundation, which is an independent charitable organisation working to build a healthier UK. She focuses on healthcare demand, and her area of work includes long-term projections of illness and health inequalities. And she's got some slides to present to us today from some work, trying to remember when this was published.
Hello, thank you so much for having me. My name is Anne, and I'm here to present this work, this report that we published in April, which we did in partnership with the University of Liverpool, where we look at the current and future patterns of inequalities in specifically diagnosed illness by deprivation. So just to provide some context, obviously, we know there is now a lot of literature about the existence of wide health inequalities in England by socioeconomic deprivation. For instance, we know about the gap in life expectancy being 8 years for women and 10 years for men between the most and the least deprived areas in England. And so what is our research adding here? So what we're doing is a lot of the commonly used measures of health inequalities, for instance, things like healthy life expectancy, make use of self-reported health. And so what we're doing is we're complementing that evidence by using diagnosed data on diagnosed illness. And this allows us to go into a lot of granular detail because we are able to see people's complete illness histories. And what we also do with the study is we are one of the first studies to project what is going to happen to health inequalities in England. And we also want to make the point that this is not just health inequalities and not just a health issue. It also has wider implications for the economy and for labor markets. And so we focus specifically on the working age population to show patterns of illness to make this point about the wider implications associated with health inequalities. So just to say that obviously this is quite general compared to a lot of the presentations that we see here, but you will see in the results that chronic pain obviously has a big role to play in some of these patterns. And so I think that's where this is quite relevant and hopefully will be useful to you. So in terms of just the introduction to our work, so the report is called Health Inequalities in 2040. I've put the link in there. So this is the result of a long-term program of research with the University of Liverpool. We actually had a previous report come out called Health in 2040, which just looked at overall patterns of illness in England and projected patterns of illness in England. And so what we're doing here is we're doing a bit of a deep dive into deprivation to see how health inequalities are going to look like in 2040. So we have very good data. Actually, a lot of the presentations here used CPRD or CPRD Orem specifically. So what we have is that, but then also linked to hospital episode statistics, so secondary care, along with ONS mortality records as well. And so, like I mentioned, we have complete patient diagnostic history. And what we do here to project is we use a microsimulation model that has been developed by the University of Liverpool. It has been very well sort of published. And I think they have been developing it for over 10 years now. So what this is doing is, and so the modeling also allows us a better understanding of sort of the dynamics between long-term illness, aging, and sort of multimorbidity as well. And so at a very high level, what the model is doing is it's taking trends in key risk factors, so things like alcohol consumption, smoking, cholesterol, blood pressure, BMI, and then using the epidemiological evidence that shows the causal relationships between these risk factors and specific long-term conditions. It is then projecting what different conditions are going to look like, the patterns, based on if we assumed current trends and risk factors to continue as is. What does that then mean for the future of illness? And then what does that mean for the future of health inequalities? And so also in terms of how we model illness, we don't, rather than just using numbers of conditions, what we do is we use a multimorbidity score. And this has been developed by researchers at the University of Cambridge, and it is called the Cambridge Multimorbidity Score. So what it does is it takes 20 highly prevalent or high-cost conditions, which together make up around 2/3 of the burden of illness in England, according to the Global Burden of Disease, and one of which is chronic pain out of the 20. And so every condition basically has a weight attached to it. So if you add up the weights, you basically get a multimorbidity score for each patient. And then within that, we are focusing on a specific threshold of major illness. So rather than looking at any non-zero Cambridge multimorbidity score, we're looking at scores above 1.5, and we're using this as a proxy of, for instance, illness that involves high healthcare costs or a high risk of mortality. And so a lot of the results that I'll be showing will be talking about major. And yeah, we are going to be looking at patterns of inequalities between 2019 and 2040. So that's just a quick overview of the methods. So going into the results. So if we look at current patterns of health inequality. So what this is showing is the prevalence of major illness broken up by 10-year age bands as well as decile of deprivation. And so the red bars are to highlight sort of working ages, so 20 to 69 years, and the gray bars are the 70 plus, the older ages. And so what we can see is actually that socioeconomic gradients that we're quite familiar with in health inequalities coming through, and coming through quite from a very young age as well. So obviously the prevalence of major illness is quite low in the youngest age group here, but you can still see that there is a gradient coming through, and it sort of grows steadily throughout working age. And so if you look at the overall average of the red bits, what we see is that 15% of people aged 20 to 69 years have major illness in the most deprived areas, which is more than double what we see for the same age group in the least deprived areas, which is 6%. And then what you can also see is that health inequalities sort of level off in the oldest age group. And that is actually because people with the poorest health in the most deprived areas don't really survive to that age. And so what you're seeing is for those who do survive, there is not a real disparity between in their health profiles between those living in the most and the least deprived areas. And so what we did is we also wanted to focus on the specific conditions that are contributing to inequalities in major illness. And what we found is out of the 20 conditions that we look at, a group of 7 conditions contribute the most to health inequalities. Unsurprisingly, chronic pain is one of those, and the most sort of prevalent condition as well. Among that, so the 7 are sort of chronic pain, COPD, type 2 diabetes, anxiety and depression, and cardiovascular conditions such as coronary heart disease, stroke, and heart failure. And this is again showing age standardized sort of prevalence of these conditions for the 20 plus population by decile of deprivation. And again, you can see that sort of socioeconomic gradient coming through quite clearly across the different conditions. And then just looking at, so that was 20 plus, and then just going a little bit of a deep dive into working age. And again, splitting that into sort of like early to middle working age, 20 to 49 years, and then later working age, 50 to 69 years. And again, you can see that inequalities in chronic pain are particularly stark in later working age. So in the 20 to 49 years, you have nearly 1 in 10 people in the most deprived areas having chronic pain. And in the 50 to 69 years, you have over a quarter of people in the most deprived areas having chronic pain. And again, you can see that gradient. This is just taking the most and the least deprived deciles. So obviously a subset of what we saw earlier. But again, those inequalities being quite stark between the 10% most and least deprived. So that's sort of like setting the scene for what are the patterns that we see currently. And so then moving on to what do we project in 2040? So unfortunately, if trends in risk factors were to continue as is, we see that health inequalities are going to stubbornly persist into the future. And this is going to have particular implications for the working age population. So what we're showing here is we're showing the change in the number of people, and working age people, between 2019 and 2040, so change in the population. And then we're looking at how much of it is down to people with major illness and how much of it is down to people without major illness. And so the red bits are showing the change in the number of people with major illness. And what you can see is, so that total number is going to be an increase from 3 million to 3.7 million. So that's the number of people, the change in the number of people, number of working age people, with major illness. And what we see is that that increase is not going to be evenly distributed. 80% of that increase will be in more deprived areas. So the more deprived half here, deciles 1 to 5. That's what the sort of curly bracket is showing. And then again, moving on to specific conditions. So when you look at how are inequalities in different conditions projected to change, and so different conditions are showing different patterns. They are not uniform. So if we take chronic pain, which is in the middle, you can see that technically inequalities are narrowing, but it is a consequence of increasing prevalence in the less deprived areas, which is not a great outcome. And then it barely not changing. So this is largely due to sort of population demographics. And so overall, our results are largely because of population changes, actually, rather than changes in prevalence at a given age. And then you can see, for instance, with other conditions, coronary heart disease, the sort of public health successes that we've seen with smoking really playing out, with there being a reduction in prevalence across the board, but the reduction being more pronounced in the most deprived areas because people in those areas have greater exposure to smoking. And you can see those benefits really seeing there, applying there. And the opposite effect for type 2 diabetes, for instance. Type 2 diabetes quite closely linked to obesity. And so with obesity sort of projected to slightly increase, and with people in the most deprived areas being more exposed to obesity, you can see that prevalence is projected to increase more, which means there is going to be a widening of inequalities in type 2 diabetes. And then finally, this is showing the number of people. So that was showing prevalence. So obviously, this is showing the prevalence applied to the population. And so this is showing how the number of people with these conditions. So these three conditions, chronic pain, anxiety and depression, and type 2 diabetes, they are out of the 7. The most prevalent in 2019. They will also be the most prevalent, continue to be the most prevalent in 2040. But you can see that change, the increase is going to be much greater in the most deprived areas compared to the least deprived 10% of areas. Sorry, I think it's a little sort of glitchy in the when the screen shared, but. And so, yeah, so I think that's the key results. So in terms of the implications of our findings, what we say is that wide health inequalities in England are projected to persist. And this has huge implications for health, but also for the wider economy. As we saw with Amardeep's presentation earlier, this poses a challenge to labour supply and worker productivity and represents a massive lost opportunity. And it also exacerbates existing economic inequalities. What we also find is that some of those conditions with the largest growth, things like type 2 diabetes, chronic pain, and anxiety and depression, primary care has a big role to play in managing those conditions. So we will see a huge increase in demand for primary care. So we have to make sure that there is significant investment in primary care to be able to manage that. We know that, for instance, there is an inverse care law, that primary care in more deprived areas are sort of underfunded and underdoctored. So there is definitely something to think about in terms of resource allocation. Prevention obviously is key. This is all linked to the trends and risk factors that we see. So obviously, tackling the biggest risk factors. But also we need long-term effort across sort of the building blocks of health. So the wider determinants, things like income, insecure work, access to green space, housing, and all those sorts of things. So yeah, I think that's it from me. Thank you so much. And this is my email if you would like to get in touch about any of this work. Thank you.
Wonderful. Thank you very much. I think that very much focused mind on what we need to be thinking about for the future. Really useful data. Okay. Can I move these slides on? Yeah, there we go. Right. Next, we've got Morag Shepherd, who should be online. Yep, great. So Morag Shepherd is a senior assistant statistician working in the Population Health Analysis Unit in Scottish Government. She works primarily on the Scottish Health Survey, which included questions on chronic pain for the first time in the survey in 2022. So going to talk us through some of that data. Do I need to turn this off?
No, you're okay. Maureen, do you want to share from your side, or do you want us to control the slides here?
I'm happy enough for you to control it, to be honest, because I feel like I'll probably mess it up somehow. So, yeah, this is fine. Right. Thank you. Great. Well, thank you very much for that introduction. I'm just going to start by saying a little bit about why we undertake the health survey, and then go into focus on chronic pain data, the module and the data. So next slide, please. Thank you. So yeah, just a bit about SHARES. So basically, the Scottish Health Survey is designed to yield a representative sample of the general population living in private households in Scotland, provides reliable information on health and factors relating to health of people that live in Scotland that we can't get from other sources. So, you know, we have plenty of data from sort of NHS records, from GP records, but to get something about the population, you really need a population level survey. So key use of SHARES data are to estimate the occurrence of health conditions, to look at the difference between subgroups of the population. So we tend to, by default, look at things like sex, age, deprivation, whether somebody has a long-term condition. We also are able to monitor trends over time, see if the situation's improving or if things are worsening. And the survey makes a major contribution to monitoring progress towards health targets, which is one of the key elements of SHARES, because you know, we're really looking to sort of hold the government to account and see how are things doing. So in 2022, which was the most recent survey that was published, data results were published last year, we interviewed 4,394 adults and 1,764 children. Next slide, please. So this is just a bit about the sort of timeline for chronic pain data being included in SHARES. So before my time, there was a consultation about the content of the survey, about foregoing, it was carried out in 2017 for the 2018 onwards content. So during that, there was a request for questions on chronic pain. However, space is always an issue in the survey, and it just wasn't possible for it to be included in that time. But it was kept on list of requests, and very much always keen to add things when we can. So in 2022, we were able to add them into the health survey for the first time. So survey runs for the full calendar year, so from sort of January to December, although I think 2022 is still maybe impacted by COVID a bit, but that is the general rule for SHARES. Data was published in December 2023, so it's our latest to date. We published some additional supplementary data, so just more breakdowns, including the chronic pain, in March this year. And our next plan is to include a module on chronic pain in 2026. So in 2022, the question, I'll comment on the data, but we asked about length of time people were troubled by pain or discomfort to identify whether it was chronic pain. We then asked about the site of pain, the impact on life or work activities, and use of support or people to get help, advice about managing pain. So 2026, it's still a bit up in the air because it's obviously got a wee bit, I mean, not as long as I think, but a wee bit of time to think about that. We did have some requests during our recent review to include questions about headache disorder and musculoskeletal conditions. So we're going to work with our policy and some other teams to see if we can sort of incorporate that in any way into the chronic pain module, as we won't really have space to have separate modules on these. So next, on to the results. So I'll just start with the adult prevalence. So in 2022, more than a third of adults were currently being troubled by pain or discomfort that lasted 3 months or more, which chronic pain, so 38%. I'm obviously not an expert in the field, but I think from speaking to policy, it was higher than we'd maybe expected it to be. Chronic pain, more women reported experiencing chronic pain than men. We also include additional demographic information shares, as I said. So as you might expect, we found that the proportion of adults who experience chronic pain increases linearly with age. So 18% of adults aged 16 to 24, increasing to 55% of adults aged 75 plus. So very much what you'd expect in that sense. In terms of SIMD, so that's our marker of deprivation, proportion of adults experiencing chronic pain was higher for adults living in the most deprived areas compared to the least deprived areas. So it was quite a big difference, 29% for the least deprived and 50% for the most deprived. So another benefit of SHARES, I don't think I've got a slide on it, but yeah, another benefit of SHARES is that we can link topics that are included. So for example, in our report, we looked at the relationship between chronic pain and mental well-being. So again, kind of what you would expect, adults who are experiencing chronic pain have lower average mental well-being than those who are not experiencing any pain. And for those, also lower than for those experiencing pain, but for less than 3 months. Next slide, please. Yeah, so this is just a quick one about the location of pain. So these are the most common types. 25% of adults who reported experiencing chronic pain experienced it in arms, hands, hips, legs or feet. 18% experienced back pain, and 9% experienced neck or shoulder pain. Next slide, please. Thank you. So yeah, this one's a bit about the impact of chronic pain on adults and the support. So adults who are experiencing chronic pain, 40% reported that it limited their life or work a lot. Almost 2/5 reported it limited their life work a little, and the remaining adults did not experience any impact on their life work. So I think that's really important to sort of get the fuller picture rather than just having like sort of the percentage who are experiencing chronic pain. And in terms of support received, the majority of adults who reported chronic pain received support from their GP, 69%, and 31% received support from a physiotherapist. So we do have more breakdowns, but those are just the sort of top ones. If you're interested, you can look at the SHES website. We've got more breakdowns. Next slide, please. So yeah, another benefit of SHES is we also interview children. So we also ask the chronic pain of children. So questions of children. So in 2022, 6% of all children had experienced chronic pain for 3 months or more. And it's more common with 8% of 8 to 15-year-olds compared to 0 to 7-year-olds, it was 3%. So prevalence higher with age. Most common types of pain experienced by children, age 0 to 15, were arms, hands, hips, legs, or feet, which is similar to adults. And then it was stomachache or abdominal pain, 1%, and headaches, facial or dental pain. So in 2022, most children suffering from chronic pain received support from a GP, and 28% received support from a physiotherapist. So a similar patterns to what we see for adults. Next slide, please. Okay, so this is the last one. This is just to say a bit about any additional analysis if you're interested, just to point you to it. That's our main website, gov.scot website. You'll find, chronic pains on there if you're interested in anything else. Like I mentioned, we have additional analysis in our supplementary tables, so age and sex, deprivation, equivalent household income, and long-term condition. We also have an interactive data dashboard that you might be interested in looking at. It's not currently as useful for chronic pain because we do only have 1 year of data currently. But we do also ask questions about long-term conditions and things in SHES, which might be of interest to you. So it's quite a great tool. It's developed by the team. So if you feel like taking a look, it's always good. Yeah, that's it for me. Just a quick overview of chronic pain in SHES.
Wonderful. Thank you very much. As I'm standing at the podium, that felt like applause for me. I think so. There was some conversation in the chat about the number of people that are appearing in that GP data for pain conditions, and I think it's really interesting that this is a data source which is a separate data source, and it's explicitly asking people whether they've been supported by a GP, and you can highlight some of the gaps. This data is all really rich, but each of them only gives us a certain lens in thinking about how we bring them together. So I can't see the chat at the moment, so I'm just going to move over in a minute. But Lynn had an interesting question in the chat. Lynn, I wondered whether you wanted to unmute and ask Kaylee. Here she goes.
Hi, Kaylee. I'm really sorry I can't be in London today. Ironically, I've hit my back, so I couldn't commute in. I was just wondering, was there any indication of the difference between deprived areas, least and most, and the use of analgesia? Because that's quite a substantial difference, and I was just wondering if there were any indications on what was the driver of that.
Yeah, so we have also looked at by region, and we've also looked by ethnicity, and we do find that quite interestingly, the ethnicities that are not white are being prescribed more analgesia, and also make up a greater proportion of those who are in the least deprived areas as well. But I think this feeds back into them still getting free prescriptions. I did also see your comment, Karen, as well about the over-the-counter prescribing, and unfortunately we don't have a way of linking that in at the moment, but it would be really good to be able to look at over-the-counter sales of paracetamol and ibuprofen and see what's really going on there and how much of that is deprivation driven. So yeah, we have been looking at multiple different covariates to kind of stratify the data and try and dig down and work out what's really going on in it, but yeah, we've decided to do that within each pain site now, because doing it broadly is just muddying things even more.
Thanks. I think another thing I'm seeing in the chat and that came across all the presentations was really about that. You can always see the trajectory when you look at deprivation. You can always see that difference. Rosemary, I thought your point in the chat was really interesting. So Room Maps, which is a project Rosemary is doing, has been looking at kind of rural patterns. And you made an important point about the measures we use. Do you want to say a bit more?
Yeah, so just briefly, so we tend to use area-based measures of deprivation, which is fine, but if you're and that works really well in urban contexts, because you've got clusters of deprived households that tend to be all together in more urban contexts, but that really tends to underestimate the sort of socioeconomic disadvantage in rural areas because the households are much more dispersed, and so that has important consequences if you're sort of basing healthcare funding and models on deprivation levels. It's just another inequality there. So we just need to think about how we do that in more rural areas and capturing that deprivation.
Brilliant. Are there other points that people want to raise that have been discussed in the chat? And I wanted to ask a little bit about kind of what comes next. So we've got these future projections. I was really interested to see kind of how chronic pain compares to some of the other conditions and different patterns. Have the Health Foundation got thoughts on what needs to happen in order to kind of mitigate against or plan based on those projections?
Yeah, so just to say, I think in terms of this work, what we really want to highlight again is that when we talk about the different conditions, and obviously everybody in this room knows this, the fact that there still isn't like a light shone on chronic pain, and the fact that this is coming through so strongly, even in our national projections. When you look at the numbers, out of the 20, the biggest increase is again going to be in diabetes and chronic pain, if you just look at the numbers of people with the condition. So I think we want to sort of bang the drum across the board for the fact that we are going to get a lot sicker with an aging population. And again, this is not hugely. We were quite surprised at the extent to which I think people were surprised by the results, whereas a lot of it is down to population demographics. So a lot of it is down to things we should be anticipating already, I guess. So I think, but the fact that the condition-specific results are something that we want to really highlight. And also just to say that within the Health Foundation, there is a team now looking a lot at implications for work and health. So there is a commission being set up about like work and health and just doing a lot more research into things again, related to some of the research that we saw here with work trajectory. So going into those areas to see what exactly are the big barriers to work. And so again, I think chronic pain will probably, I would imagine, feature quite heavily there. So that bit of work is happening on the side. But specific to this analysis, we have also, our baseline year actually here is 2019. So obviously this is we were limited by the data sample that we had. This is pre-COVID. We haven't been able to, for instance, look at long COVID or things like that. But just to say that we are applying for more up-to-date data. So the hope is that maybe in like a couple of years' time, we would be able to replicate this analysis. And actually, with the point just made, we are also applying for an urban-rural split as well to recognize that that is something that we need to dig a little deeper into. And so hopefully we would be able to look at in a little bit more depth, have like a more recent timeline in terms of our baseline. But also look at these more interesting patterns of like urban rural as well, in addition to deprivation, I think. So.
Any final thoughts? Anyone online? I don't think so. I think it's been a really interesting discussion. So I'm now going to close the session. I think first thing I want to say is thank you to all of the speakers, all of the people who've contributed online, and thank you to Michael who puts this whole thing together, invites everyone, organises everything. Really nice piece of work. So I think the big thing for me about this is just the ability to pause and think about that data, share it with a range of different people and get some different views in the room. On a practical point, Michael will be sharing presentations and videos afterwards. If there are things that have happened in the discussion, there's been various promises to share bits of data or connect to different people. So if we can help with any of that, give us a shout. I think, as I say, for Versus Arthritis, this event is really about bringing together a range of expertise and a range of perspectives. I think the 3 different sessions we had have been really interesting, kind of to go from kind of your experience, sort of actually delivering in the NHS. So we've got that, and then we've got population health management piece and the epidemiology piece, actually having those shared discussions. For us, I think the really important thing is that we want all of the research and the data to have impact. So that's how that happens, through those discussions. I think data can tell us how things are. Data can tell us how things are changing. Data can tell us how things might be in the future, but none of that translates to action unless we have these types of discussions. So I think that's really important for us to do. I think the other thing is we need, and it's come up throughout the conversations, those strong connections between, it's not just the data analysts and it's not just the people receiving the data, but it's also the people the data is about. And so where we have these pieces where there's some really nice co-production going on, there's some really nice kind of reference of bringing people in, but I think we can always do more than that. We need to make sure that whatever we're looking at, we've actually spoken to the people that the data is about so that we are interpreting and making the actions that make a difference. Thank you very much, everybody. I'm now going to pull this to a close. For those who are in the room, we have lunch around the corner. Just double checking, I'm not promising people so much as we don't have. Lovely to meet you all. And Michael will be sending you feedback. This is an event that we do every 6 months. We're really keen to kind of develop and improve it. So do give us your feedback and we'll try and improve the event each time for you. Thank you very much.